Good morning and welcome to the first day of Arizona Department of Health Services Maternal Mortality Summit. We are so glad that you were able to join us this morning and throughout the week virtually. While we'd much rather be in person, we are so glad that we're able to continue to share this valuable information in the virtual environment. We appreciate your patience and participation in this summit focused on preventing maternal mortality and severe maternal morbidity among Arizona's women and other birthing individuals. My name is Natalie, your MC for today's event, and here are the highlights of the agenda for this week's summit. Each of you should have received a copy of this agenda in your confirmation email on August 14th. Today we start our update with an update from the health team at the Arizona Department of Health Services about recent achievements and ongoing activities related to improving maternal health outcomes in Arizona. Next, we are honored to have the national leader in maternal health with us today, Nicole Gonzalez, who will be providing a keynote address about innovative approaches to caring for Indigenous women in Arizona before, during, and after pregnancy. She will start at 10 a.m. To close out the day, we are excited to highlight 3 Arizona providers as they discuss how to reduce risks and barriers for Arizona women related to perinatal mood and anxiety disorders, substance use, and intimate partner violence. This panel will start at 11 a.m. We hope you have opted to join us tomorrow for the joint meeting of the Arizona Maternal Health and Arizona Tribal Maternal Health Task Forces from 9 a.m. to 1 p.m. The Arizona Maternal Health Task Force has been an important collection of partners that has collaborated with Arizona Department of Health Services on the development of our state maternal health plan and allowed our maternal health programs to glean insight from both clinical and non-clinical providers in our state. During the meeting tomorrow morning, we have planned an important presentation from the Intertribal Council of America to discuss Indigenous Framework Approach as a tool for cultural resiliency. Each of the presenters today and the presentation tomorrow from the Intertribal Council of Arizona will set us up for a facilitated discussion about how we can collectively improve maternal health outcomes in our state. We hope you can join us. If you did not originally register for tomorrow's Maternal Health Task Force meeting, but would like to be involved, it's not too late. Please email maternalhealth@azdhs.gov. You'll see that in the lower right-hand corner of these slides. You'll see it right now on your screen. This email, as you can see, is in front of you on the lower right-hand corner. Lastly, we are offering 2 opportunities to participate in the session on breaking through bias in maternity care, a virtual implicit bias training, which was designed and will be facilitated by the March of Dimes and Quality Interactions. This is a unique and exciting opportunity for participants as this implicit bias training is specifically designed for maternal healthcare providers. These live sessions will take place on Thursday and Friday. If you didn't sign up for either one and would like to participate in a self-paced module at a later date, please contact maternalhealth@azdhs.gov to ensure you can take part in this incredible opportunity. The last set of announcements is a little housekeeping. As a reminder, as we move through the presentations, you may have questions for the speaker. Please use the Q&A section, the Q&A box, for these questions. Also, if you are looking for CEUs, please make sure that you have your first and last name in the chat box so that we have part of the verification. We've got a couple of things going on with verification for CEUs. The first step is to put your first and last name in the chat box. And as far as the Q&A, as I mentioned earlier, we will be collecting those questions for each panelist. And when we have time, hopefully we'll have time for all of your questions. We will be asking the questions to the panelists as a moderator. I will moderate those. As a reminder, this session is being recorded, including the chat box and the Q&A box. So just make sure that whatever you put in there, even the private chats, are something you wouldn't mind someone else seeing. We also have closed caption services. So if you would like to have your closed caption, you can activate those along the bottom of the webinar panel. You'll see a closed captions icon. If you're not seeing them, click on the icon and you should be able to see an option to activate your closed captions. So again, continuing education units or CEUs, if you are receiving them for your participation today, again, make sure your name first and last is in the chat box, and we are going to be giving you 3 keywords. These keywords will be distributed throughout the summit, and they're the check to make sure you are actually here at that time to be able to capture them. We'll be using those in the evaluation. So here's your first word. Are you ready? The first word is green, the color green, Green. So your first word for CEUs is green. All right, we're ready to get started. I want to introduce you to a very special guest today. Desiree Green's background spans the field of public, maternal, and child and environmental health, nutrition, finance, education, and holistic modalities. She is currently the Healthy People, Healthy Communities IGA and Family Planning Program Manager at the Arizona Department of Health Services. She is also a certified yoga nidra and meditation practitioner and is currently in an advanced yoga teacher training program. She's going to provide us with an opening blessing and recognition for our meeting today. Desiree?
Good morning, everyone, and thank you for having me here today to provide a healing meditation and a blessing. And today we will start with some movement in order to release any stress and to prepare us for all of the great information that will be shared during this summit for the next few days. So let's go ahead and move our shoulders up and down. We're going to do this 3 times to release any tension in the neck and any tension in your upper back. Okay. Now that we've put some movement in that upper area, which normally has a lot of stress, go ahead and sit straight up in your chair. Make sure that your feet are grounded and place your palms up in your lap to receive the healing energy for today's session. Now, as you do that, gently close your eyes. As you're closing your eyes, feel your whole being beginning to soften. Breathe in fully. Exhale with a deep sigh. Again, breathe in fully. Exhale with an even deeper sigh. Let's take one more cleansing breath. And exhale. Feel a sense of comfort and safety and peace wash over your body. As you sit in this meditative state right now, bring the following intention into your life. I am totally open to something amazing and abundant coming my way today and for the rest of my life. Hold that intention with you for the rest of the several days of this summit, as you will be receiving a lot of great information from amazing people working in maternal child health. As we're sitting here with our eyes closed and breathing in that healing meditative affirmation, let go even more. Let go of anything that no longer serves you. Relax and rest back. Know that nothing else matters right now. Everything is okay, and that you are simply here to feel your body, calm your mind, and listen. Now, imagine that you are standing on a magnificently colored pathway, different from any other that you have ever seen. There are a multitude of colored stones, reflecting the light in 1,000 prisms. The colors penetrating through your feet as you walk. As you follow this path, the air vibrates as it moves around and through you. You sense that you are approaching a healing space. You walk into the peaceful courtyard in which there is a fountain. The force of this fountain cascades in a rainbow of colors, dancing throughout the entire courtyard. Millions of vibratory rays from red to orange, yellow to green, blue to violet, and crystal, reflecting everywhere. This is a fountain of healing energy, the same energy that enlivens and heals your body. You walk towards the fountain and hold out your hands to gather a little of this energy. You feel the energy from the fountain pouring into your being. Feel yourself filled with this vibrating, shimmering, pulsing colors flowing around and through you. Feel the tingling light energy moving with delicate intelligence to the places where you may be holding stress, tension, inflammation, and pain. Breathe into those areas with me. Let's take a deep breath in together and exhale out any of that you no longer need. The glimmers of your own vitality are starting to bubble up, simmering and rolling to a boil deep inside. You are certain, you know that with your whole being, that you are healed, that you are whole, and that you are expansive. Let's sit in peace in this healing garden for a little longer and just breathe normally into all of those colorful healing prisms. Enjoy this beautiful space, surrounded, protected, deeply resting. Notice how your whole body responds. Feel how peaceful and calm you are, more relaxed and more content. As we move away from that peaceful garden, start to slowly feel yourself beginning to rise to your self-awareness. Notice the rising and falling of your breath. Slowly begin to come back to your physical body. Wiggle your fingers and your toes, bringing energy and removing any stagnant energy in the body in those regions. When you feel the impulse, begin to move around a little more, moving your shoulders in circles to the front, moving your shoulders in circles to the back, sealing in a lot of that healing energy from the garden where we just were. As you bring that movement back into your body, let's bring our healing intention back into the forefront one last time. I am totally open to something amazing and abundant coming my way today and for the rest of my life. Now, please sit still. Bring your palms together in a prayer-like fashion at your heart center. And I'm going to end this healing meditation with a Native American blessing. May Mother Earth guide your feet. May Father Sky keep his arms around you. May Grandfather Sun warm your cold days. May Grandmother Moon keep the glow in your heart. May the star nations light the way to the next destination. And the Great Spirit always keep you shielded from pain. Thank you again for allowing me to guide you through a healing meditation and to provide this blessing as we embark over the next several days to learn about maternal child health and maternal morbidity and mortality. Let's bring our hands together and bow forward in unison, healing in this sacred time together. Namaste. You may open your eyes and enjoy the rest of your day. Thank you.
Thank you, Desiree. What a beautiful way to start our time together in a grounded and connected way on such a important topics. So thank you again, Desiree. Next, I would like to introduce to you Patricia Tarango. Patricia currently serves as the Chief for the Bureau of Women's and Children's Health, Division of Public Health Prevention Services for the Arizona Department of Health Services. In her role as Bureau Chief, Patricia functions as the Arizona Primary Care Office Director and the Maternal and Child Health Director. A proud native of rural Arizona from Pinal County, she has dedicated her career to improving access to care for Arizona residents. Patricia is a member of the Arizona Public Health Association, Arizona Rural Health Association, and served previously as community representative on Chicanos para la Causa, Early Childhood Head Start Policy Council, and the Arizona Medical Student Loan Program Board. Please welcome Patricia.
Good morning, and welcome again to the first ever Maternal Mortality Summit hosted by the Arizona Department of Health Services, Bureau of Women and Children's Health. I'm so excited to see so many of you join us here today. We have a fantastic agenda, excellent speakers, and I'm hopeful that you will find today's presentations inspiring. I want to give a shout out to VEER Consulting Conference Management for the work behind the scenes and assuring that we provide a professional presentation and virtual summit for you all today. I also cannot move forward without giving a huge thank and recognition for the amazing Arizona Department of Health Services maternal health team that I have the honor and privilege of working with every day. They are the amazing people that are bringing the summit together and that help put the agenda together. So thank you so much, ADHS team. You guys are amazing, and I appreciate every single one of you. Next slide. Thank you. So this slide here, you can see all of these awesome headlines, which are basically showcasing the movement that we're seeing, not just in the nation, but here in Arizona as well. As you know, there has been quite a bit of momentum building to recognize and address maternal mortality as a growing public health concern, both nationally and within Arizona. At the national level, we saw the passing of the Improving Access to Maternity Care Act and the Preventing Maternal Death Act. And here in Arizona, the passing of Senate Bill 1040. Our Bureau is working hard with our partners to use this attention and new resources that are being made available to improve maternal health outcomes for women and families in our state. Next slide. ADHS has a long history of providing essential maternal and child health services across Arizona, from our home visiting programs, high-risk perinatal program, Health Start, McVie, teen pregnancy program, and a host of others. We have actively worked with our community partners to ensure women and children have access to the services they need. I want to bring your attention to the increasing activities Arizona Department of Health Services has seen over the last 2 years or so related to maternal health. This slide you can see here really depicts how busy we've been at the Bureau of Women and Children's Health addressing maternal health issues. I just want to highlight a few of the achievements listed on our timeline here. So I want to be sure to pull out that in October of 2018, we actually held our first maternal mortality and severe morbidity meeting in partnership with the Arizona Perinatal Trust and the March of Dimes. It brought together a whole host of stakeholders, many of which are part of our maternal health task force and that are with us here today. In January of 2019, we had some tremendous work and bringing a very focused attention to the need to establish a tribal maternal health task force which is a very important piece of our puzzle in terms of addressing maternal mortality. We also had the introduction of Bill 1040, which was passed and signed into law in late April of 2019. That summer, last summer, was really just a whirlwind of activity. We actually, through our partnership with our task force members, we were able to develop a maternal mortality action plan. We applied for AIM, and we also applied for 2 amazing grants that are actually supporting our summit today. We applied for the CDC Maternal Mortality Review grant, and then we also applied 2 weeks later for the Maternal Health Improvement or Innovation grant that we'll hear more about that a little bit later. We also were awarded both of those grants. These were very competitive grants, and I'm happy to say that Arizona is one of 9 states in the nation to have received the Maternal Health Innovation Grant. So kudos to all of those that worked on those grant applications. And since then, I'll just jump right over to where we are today. We've implemented the recommendations that were submitted as part of a report associated with Senate Bill 1040. We are executing both the CDC grant and the HRSA grant. And I'm proud to say that we released the first ever severe maternal morbidity report in Arizona. You can find all of this information on our landing page, and we'll provide that link a little bit later. The reason that I wanted to give you some background is to really highlight an example of what is possible when multidisciplinary partners across our state come together for a common goal. We have made huge progress in just 1 year, and we certainly don't want this momentum to stop. We have to give a huge thank you to all of our partners who helped us be successful with Senate Bill 1040, the AIM application, the HRSA Maternal Health Innovation Grant, and the CDC Erase Maternal Mortality Grant. We couldn't have done it without you, and we wouldn't want to do it without you. This Maternal Mortality Summit is a great way for us to celebrate how far we've come in just a short period of time. And I hope you will see this as a turning point into our next phase of really putting our ideas, resources, and energy together to truly make an impact on maternal health outcomes in Arizona. Next slide. Before I turn it over to Heidi and Clark, I'd like to tell you a little bit more about some of the ongoing activities here at the Department of Health Services. It's important to know what all of these activities, the funding and Senate bills are aiming to do. This slide shows a summary of the Governor's Maternal Mortality Action Plan, which was released last summer. This is our guiding document when it comes to maternal health activities in our state. Engaging the Maternal Health Task Force last year, we were able to develop a 5-year action plan. And I'm proud to let you all know, not only is this our Maternal Mortality Action Plan, but it's actually part of the department's strategic plan. This document is available on the department's website and on our maternal health landing page. Our goal is to reduce overall mortality rate by 5% in 2 years and 10% in 5 years through a few key activities. We want to increase pregnant and postpartum women's awareness on postpartum warning signs, for which we are engaging our home visiting programs and launching a social media campaign. We want to expand access to case management, home visiting, insurance, and prenatal care, for which we are also working with our home visiting programs and other community partners to help women and families navigate our health system. We want to support workforce and workforce capacity for Arizona providers, which we are actively beginning with our AIM initiative, a telemedicine initiative, and providing trainings like the implicit bias training on Thursday and Friday of this week. We want to improve surveillance of maternal mortalities and morbidities. which is the primary role of the Maternal Mortality Review Program. The Maternal Mortality Review Committee, which many of you sit on, and we thank you for your continued partnership and sharing your expertise. And finally, supporting the systems of care that serve pregnant and postpartum women in Arizona, for which we are engaging multidisciplinary stakeholders through the Maternal Health Task Force, our AIM initiative, and other programs within and throughout the state. Next slide. Next slide, thank you. So shifting gears just a little bit, wanted to share with you all that we just recently completed our 5-year statewide maternal and child health needs assessment. And this was completed in partnership with our steering committee, and many of you sit on and are members of our steering committee, with the University of Arizona, the Diné College of the Navajo Nation, and the Intertribal Council of Arizona. This by far is one of the many ways that our Bureau engages our diverse communities and families to help us understand their needs and preventative and primary care services. This needs assessment leveraged over 7 different approaches and reached over 1,500 individuals across the state. You see on the slide a map of our reach in our qualitative data collection process. We are also excited about our partnership with the Navajo Department of Health, Diné College, and the Intertribal Council of Arizona to identify the unique needs of our tribal indigenous communities in our state. This information will support the agency's health equity work and guide us in the right direction in developing or revamping our public health programming to interventions that can make positive progress across our tribal lands. Next slide. So this slide, I'm really proud and happy to be able to share with you all. This is hot off the press. We just had our last Maternal and Child Health Steering Committee meeting last Thursday, and we were able to identify, based off of our Maternal and Child Health Needs Assessment, our priorities for the next 5 years. So I wanted to quickly go through these with you. So the first one is for women or maternal health, and it is to reduce and eliminate barriers to ensure equitable and optimal health for women. For infant and perinatal, we want to promote equitable and optimal care and protective factors for mothers and infants before, during, and after pregnancy. For children, we want to strengthen emotional, physical, and social services to achieve an equitable and optimal development for children. For children, youth with special healthcare needs, we want to strengthen systems of care to advance inclusivity and promote equitable and optimal outcomes for children, youth with special healthcare needs. And for adolescents, we want to enhance equitable and optimal initiatives that positively impact the emotional, physical, and social well-being of adolescents. These priority statements give guidance to our Title V Maternal and Child Health Block Grant, which is a $19 million investment between Arizona and the U.S. Department of Health and Human Services, Human Resources Services Administration. We are very proud of the work, and I'm present the new priorities for our state, especially the priority that we've identified to support our women maternal health population in Arizona. Next slide. Thank you. I wanted to also just take a minute to highlight some of the other activities that we're engaged in here at the Bureau of Women and Children's Health. I would be remiss if I did not give a brief shout out to some of the other programs within the Bureau of Women and Children's Health. You already heard a little bit about the awesome work we're doing related to maternal health, but I wanted to showcase just a few other areas. In fiscal year 2020, ADHS home visiting programs provided over 45,000 home visits to families across the state. And I'm proud to say that in the time of COVID-19, the number of families we were serving has held steady, and we have successfully adjusted our programs to provide virtual visits and virtual classes. For PRAMS, or the Pregnancy Risk Assessment Monitoring System, this is a joint research project between the Arizona Department of Health Services and the Center for Disease Control and Prevention, or the CDC. Each month, Arizona PRAMS will ask 1 in 30 new mothers in Arizona to share their experiences before, during, and after pregnancy. These experiences include things like access to prenatal care and postnatal services, interpersonal violence, substance use behaviors, access to reproductive health, etc. Data is necessary to help Arizona measure its performance for the identified maternal child health priorities and our maternal health efforts, as it's the only data source of the kind for the state. We are excited to see that the current response rate for PRAMS is currently at 50% in just 3 short years, and we are aiming to meet the national standard of 55%. And I'm confident that we will be able to hit that measure by next year. This data is important, as I mentioned, in order for us to meet national standards. It's important for us to be able to share then that information that we're gathering through PRAMS with our partners and our stakeholders to help maternal health improvement efforts. With regards to adolescent health, the Bureau's Adolescent Health Initiative has adopted the U.S. Health and Human Services Office of Population Affairs 5 essentials for developing healthy youth. Through our teen pregnancy prevention, bullying prevention, and adolescent well visit initiatives, we're providing and developing programming that enhances the knowledge and capacity of young people. From providing them with skills for transitioning to healthy adults to empowering them to be the change in their communities, all in an effort to create safe environments where youth live, learn, work, and play. Now on to preconception health. The Preconception Health Alliance was reestablished in late 2019 in partnership with the Arizona Family Health Partnership and the Arizona chapter of March of Dimes. They will be developing an action plan focused on strategies to increase awareness about preconception among health providers and the general public. I want to, it's not on this slide, but I did actually add a bullet, and I'm going to take the privilege of covering the primary care workforce incentive programs, which currently has 689 primary care, dental, and mental health providers participating in the National Health Service Corps, State Loan Repayment, J-1 Visa Waiver, and National Interest Waiver Program, which are offering services on a discounted sliding fee scale based on the ability to pay in health professional shortage areas of the state of Arizona. And with that, I'm going to turn it over to Heidi. And I just want to once again welcome you all to our first summit. I'm really proud of being able to host this event, and I'm looking forward to learning with all of you. Thank you.
Good morning, everyone. My name is Heidi Christensen. I'm the Maternal Health Innovation Program Manager, and along with my colleague Lynn Lane, we manage the maternal health efforts that fall under the State Maternal Health Innovation Program. The State Health next slide. The State Maternal Health Innovation Program is funded by HRSA, the program that was established to improve maternal health outcomes in Arizona, including prevention and reduction of maternal mortality and severe morbidity. Our work aligns with the Governor's Gold Council on maternal mortality, and we work jointly with the Maternal Mortality Review Program. As you can see from this slide, our activities fall under 3 main categories. First, the Maternal Health Task Force, which all of you will be able to take part in tomorrow, and we hope that you'll all stay with us. The Maternal Health Task Force is comprised of multidisciplinary stakeholders engaged in shifting the paradigm of adverse maternal health outcomes. The task force develops and informs strategic planning, And at the recommendation of our original task force members, we've also added the Tribal Maternal Health Task Force. The second is to improve data collection. The State Maternal Health Innovation Program and Maternal Mortality Review Program work closely to improve the collection, analysis, and application of state-level data. And third, to promote and execute innovation. This is where the bulk of our activities fall. It includes all of our work towards increasing awareness, reducing disparities, improving access to care, supporting workforce capacity and systems of care. Next slide. And the strategic plan for this coming fiscal year is to offer training and education on early warning signs for community health workers and other providers. Our last task force meeting, we discussed this, and the task force chose to go with the A1 post-birth warning signs education. And we're also going to be launching a postpartum warning signs campaign and supporting efforts to increase implicit bias training amongst providers, which all of you will be able to take part in as part of this summit later in the week, and promoting routine screening for perinatal mood and anxiety disorders, and launching our AIM initiatives with birthing hospitals. Next slide. And the Alliance for Innovation on Maternal Health, or AIM, is a national data-driven maternal safety and quality improvement initiative. Arizona pursued becoming an AIM state at the recommendation of our Maternal Health Task Force, and we appreciate their continued support in these efforts as we move forward with AIM. Next slide. And our partners at the Arizona Hospital and Healthcare Association will be working with hospitals and birthing centers across Arizona to implement and provide technical assistance on safety bundles. Based on Arizona's maternal mortality and morbidity data, the AIM Steering Committee has chosen to move forward with the Severe Hypertension in Pregnancy Safety Bundle to start our efforts. For more information about what is included in those safety bundles, you can go to their website, which is safehealthcareforeverywoman.org. Okay, you can go to the next slide. And finally, I just wanted to give another shout out for tomorrow. The Maternal Health Task Force and the Tribal Task Force will be meeting tomorrow jointly, and all summit participants are encouraged to attend. We've carefully selected the topics for today to feed into tomorrow, and we really value and need your perspective. And if you have an interest to continue in participating in the task force, please contact myself or Lynn. You can either reach out to us directly at our personal work emails or the maternalhealth@azdhs.gov email. And I'd like to turn it over to Clark, our Maternal Mortality Review Program Manager.
All right, thank you so much, Heidi and Patricia. Hi, everybody. My name is Clark Bear, and I am the Maternal Mortality Review Program Manager for the Arizona Department of Health Services. And we're really excited to tell you a little bit more about the Maternal Mortality Review Program because we have some exciting things coming down the pike in the next couple of years. So as a little bit of background, the Maternal Mortality Review Program was established back in 2011. And essentially, it created a multidisciplinary team of clinical and non-clinical stakeholders who come together to review maternal deaths that occur in Arizona and identify areas and opportunities to prevent those deaths in the future. And so often when we're talking about the focus for our program, we like to bring forth this pyramid that you'll see on this slide that demonstrates the increasing severity of outcomes that can occur with a pregnancy. And so, of course, the Maternal Mortality Review Program, or the MMRP, is focused on those top tiers. So the Maternal Mortality Review Committee reviews every maternal death that occurs in Arizona within 365 days of pregnancy. So a woman or an individual who doesn't identify as a woman but also gives birth, who could potentially pass away during pregnancy, potentially she became pregnant, and the pregnancy ended without a live birth and she died within a year of that time, or a woman who made it to full term, had a live birth, and then passed within a year of that birth. We review all of those deaths, and we estimate that we will review about 60 to 80 deaths per year. But we also want to make sure that we are learning from and putting forth data about some of the other severe circumstances that happen around pregnancy, which is why we produce reports related to severe maternal morbidity that's occurring in our state. And like Patricia said, we just released our first severe maternal morbidity report this spring, and I'll show you where you can find that in a couple of minutes. So even though our program was established in 2011, it's been largely unfunded since that time. But Arizona was lucky enough to receive a grant from CDC last fall called the Preventing Maternal Deaths Grant, or we like to call it the Erase Maternal Mortality Grant, from which we were funded for $450,000 per year for 5 years for two main reasons. You can see sort of the program goals and the outcomes here, but I like to think that this grant does two main things. The first is to make sure that we have enough capacity and staff time and other resources to bring forth the most complete information about each maternal death that's occurring in our state so that our committee can review and make recommendations based on the best information that we can provide to them, so they're informed recommendations. And the second goal of this grant is really to help us move beyond just reviewing and reporting on maternal deaths in our state to actually start having more capacity to implement these recommendations in a collaborative and targeted way. So that's something that we are really looking forward to moving into in the next 4 years. We're almost done with our first year, but of course in year one, we've already been able to implement one of our recommendations by partnering with the Maternal Health Innovation Program on the AIM safety bundles. So we are partially funding the implementation of the hypertension bundle, which we're really excited about. And as we produce more recommendations moving forward, we're excited to partner with many of you on the webinar on implementing other recommendations. Anytime we meet with new stakeholders, I do want to provide just a quick overview of what a maternal mortality review looks like. Sometimes it's a foreign concept to our stakeholders that we're talking to or engaging with. And we like to think of our process as being cyclical, and that for every calendar year, we identify potential maternal deaths by using a mix of vital statistics data and hospital discharge data to come up with a list of women who had died within 365 days of their pregnancy. And from there, we try to pull as much information by requesting hospital records, patient provider records, police records, EMS, anything you can think of, you name it, so that we can bring forth a de-identified narrative about each case to the committee. And like I said, the committee reviews between 60 to 80 of these deaths every year, but for every single one, we go through a standard process where we're making a few key determinations about these deaths, some of them being pregnancy relatedness. So even though this woman died within 365 days of her pregnancy, would she have died if she hadn't been pregnant? Causes of death. So of course the death certificate tells us what the immediate and sometimes the underlying causes of death were, but we know that there are so many other circumstances and factors that could have contributed to that death that we want to make sure we're capturing all of that information as well. Preventability. If you've seen us do a data presentation from our 2012 to 2015 maternal mortality data, you probably remember that our committee determined that 89% of those deaths were preventable, which is a huge reason and a huge factor why it's so important for us to be putting forth recommendations to prevent these deaths in the future, which is the final and sort of most comprehensive process that we do for each of these deaths. And again, going back to that cycle, the more that we do these reviews and the more recommendations that we're putting forth, the more that we're able to really see what is not constantly, but consistently happening in our state, and maybe some things that aren't consistently happening in our state that we need to address to improve maternal health outcomes for women in the future. And so just to give you an idea of what we do with those recommendations, for right now, we are actually finishing up our reviews for 2016 and 2017 maternal deaths. And we are going to be summarizing all of those deaths and putting them into a report that is due to the governor and our state leaders by December 31st. But essentially, once we have that report together, it will summarize all of those key findings and all of those recommendations that our committee wants to put forth so that we can start to disseminate those and implement those with our partners. So we definitely consider the Maternal Health Innovation Program a key partner in helping us move forward these recommendations, but we know that there are so many other stakeholders out there that we should be working with and connecting with on a lot of these ideas and opportunities. So you can look for, I'm going to talk about when the data will be available again moving forward, but if you think that this might be an opportunity for you or your organization, a group that you're part of, to partner with us in this, please feel free to reach out to us. Our email is right in the corner, maternalhealth@azdhs.gov. And so I know we've been telling you about all of this data, and we didn't actually go through any of this data with you. And so I wanted to point you to the two key reports that we have on our website. The first one we've talked to you about already. It's the 2016 to 2018 Severe Maternal Morbidity Report. And this is our most updated data. It was released this spring. And then we also have a program report that summarizes maternal mortality data from 2012 to 2015. That is also available on our website. And then, of course, coming this January, so December 31st, early January, we are going to be publishing this new report on maternal morbidities and fatalities in Arizona. This report will include the fatality data or the mortality data from 2016 and 2017, so we'll have some fresh findings there. And then it will also include morbidity data from 2019. So all three of us, Patricia, Heidi, and I, have been pointing you to our website. We welcome you to go there at any time. It's azdhs.gov/maternal health, and you can find links and information from all of the programs that Patricia was talking about earlier, Maternal Health Innovation Program, Maternal Mortality Review Program, and of course all of our reports as well. So thank you very much for that. And I know we're going to turn it back to Natalie to see if there's any questions or comments that we should address.
So thank you, Patricia, Heidi, and Clark from the ADHS team. We do have a few questions. Now, I want to remind you that if we don't get to all of the questions, we will have a post-summit answer that will be posted up on the HealthWise on the website. So we'll try to get to all of the questions, but if we don't, then we will do our best to even post-summit get your answers. So first question, in regards to Goal 1 and Goal 2, how can we help clients talk to the insurance companies to cover both home birth services for low-risk women, which include prenatal and postpartum home visits, and hour-long visits to cover that first goal of awareness? So how can we help clients talk to their insurance companies? Who would like to field this one? Patricia, Clark?
Yeah, hi, this is Patricia, and I will take a shot at this, and then I will ask Heidi and Clark to chime in. I think one of the ways that this can be addressed is actually through our task force. I think through participating with our task force and providing that level of feedback and interest, we could very quickly, as a group, develop a strategy on how to best address that. I think for me, the takeaway is having a unified approach is a great strategy. That way, all parties will be talking the same talk and have the same goal in mind. Oftentimes, when our stakeholders, while there may be some activities that here at the Department of Health Services we can't take the lead on, but it's important for us to know what those activities are, because oftentimes our state leadership will depend on the Department of Health Services to respond to different interests that our stakeholders are bringing to the table. So I think participating with our task force, bringing that to our attention, and then developing a plan that we can all support is a great place to start.
All right, next question. How can practitioners assist to increase responses for PRAMs? Patricia, is that one you want to field as well?
Sure, I can take that one as well. So one of the things that we encourage our, or that we really rely on our partnerships with the different entities, whether they be clinicians, hospitals, birthing facilities, WIC clinics. We have a whole host, local county health departments. We have a host of organizations that we typically reach out to help us promote PRAMs. We actually have materials that are available free of charge for hospitals, for any clinical settings, any social service settings. All you need to do, again, you can reach out to us on our website or on our email address for maternal health, request the PRAMs information, and we would be happy to get the information out to the different settings. Again, it's promotional materials. It's very simple. It's available in English and Spanish, and we'd be happy to provide that piece of information to you all.
All right, Heidi, the next question is for you. Will the CDC Hear Her campaign be included in the program to raise awareness of warning signs?
Yes, the Hear Her campaign was just released last week, and it will be incorporated into our efforts moving forward. We have the A1 information, the Hear Her campaign from CDC, which has some beautiful imagery and messages from mothers who've experienced postpartum complications. I encourage you to look at their website. And AIM also has some postpartum information. So we're going to combine all three of those sources in our messaging.
All right, the next question is, as I'm new here, are there home visits available to SRT women, and are they already occurring? Who would be the best to answer that one?
Heidi, you can chime in. We do currently have, our home visiting programs are really pretty diverse. We have all of our programs are evidence-based or evidence-informed, and we do have the Health Start program does provide services for women that are that have substance use disorder or that are in recovery and treatment. And so if someone's interested, they can reach out to us through our email address, and we'll make sure that they get in contact with the correct program manager here at the department.
All right, next question. Are there currently stats for individuals not identifying as female but become pregnant and suffer a death?
That's a great question. This is Clark. I can take that one. And at this time, our data from 2012 to 2015 does not identify those specifically. And to be honest, vital statistics at this point, I don't think gives us that information on a death certificate. The only way that we would be able to identify that somebody is identifying with another gender besides female would be through hospital records, provider records, other social context that we can pull. And I'm not sure, to be honest, that we have an example of that yet. Of course, we're open to it and looking for it. So if that were to occur, we would report that in some way, but I'm not sure we have an example in Arizona of that happening yet. We just want to be inclusive and ready just in case it does.
All right, and so this will be our last question of this segment. Clark, this one is for you. In pregnancy-related and cause of death, have you found that any of the people have hemoglobinopathy, like sickle cell or any other type of blood disorder?
That's another great question. And I would encourage whoever asked that question, or if anybody has specific questions about specific disorders or causes of death that we may have seen, please email us and we can sift through all of our data. I'll be honest, I started in February and I'm not as familiar with the data that we saw from 2012 to 2015, but we have it, and we can certainly sift through those things for you and pull out what some of those recommendations may have been. We have to make sure that we're keeping everything as de-identified as possible, so we can share aggregate data with you about specific causes of death or specific circumstances if you email us at the maternal health email address.
Thank you very much, Clark. And so I want to again call your attention to the lower right-hand corner of this slide, maternalhealth@azdhs.gov. That's how you can reach out with your additional questions. So right now, thank you again, Heidi, Clark, and Patricia. Right now, we're going to go on a 5-minute break. This is a quick grab a coffee, do a little stretch, maybe roll your shoulders some more. We'll call it a bio break. And we will be starting promptly at 10:05 with Nicole Gonzalez. So thank you, everyone, and we will be back at 10:05. Welcome back. Hopefully everyone had a chance to stretch their legs and grab a coffee. It is now my pleasure to introduce our keynote speaker, Nicole Gonzalez, who's a nurse midwife from the Navajo Nation. She grew up in the Four Corners of New Mexico and now lives in San Ildefonso, Pueblo territory with her family. She is an Indigenous feminist, a published author, inspirational speaker, marathon runner, and healer on the path. She has dedicated her life to addressing Native American maternal health disparities around access to care, while reclaiming Indigenous birthing practices and supporting the return of Indigenous midwives to communities. She is the founder and executive director of Changing Women Initiative, a Native American-led women's health collective dedicated to renewing cultural birth knowledge to empower and reclaim sovereignty of Indigenous women's medicine while creating the country's first Native American birthing center. Please welcome Nicole.
Hi, everybody. It's customary for us to introduce ourselves in Navajo first. So, Nicole Gonzalez Nishe, Gwash Chi Nishle Do Tochi Ni Bashish Chin, Ishka Iswe Deshache Nanish Deshanale. I want to thank you all for allowing me to speak with you today via Zoom. I want to say with the raise of hands who's wearing their pajama bottoms with their nice top. Really, I actually enjoyed getting dressed up today for this presentation because normally it's like a t-shirt and scrubs or some sort of comfortable clothes to take care of families here in New Mexico. I'm excited to talk about innovative approaches to supporting Indigenous women in Arizona. I've been a nurse midwife for the last 8 years, and I've been a nurse for the last 16 years and primarily work in hospital, and then made the shift to attend births in homes the last 2 years. And so I think what I really appreciate with the hospital experience that I have is to get a good sense of like how those systems function, but also now working primarily in community, I get the perspective of the user side of that system. So a lot of our families that we take care of through my organization, Changing Initiative, we provide home birth services, well women care, nutrition, access to foods from native farmers, as well as a doula and traditional medicine and herbal medicines. And so having to work outside of the system that hospitals, Indian health services definitely has taught me a lot about what our native communities are facing when it comes to trying to access care in a very complex system. And so I'm excited to share that knowledge with you today, as well as some innovation and some ideas on maybe troubleshooting some of the issues that are going to be addressed. There is going to be some information, statistics, but I don't like to spend so much time on that. I feel like in academia, we do spend a lot of time talking about disease process and statistics. And I think it's important when we take care of Indigenous communities that we've been pathologized over the centuries, and there's a lot of emphasis on our death and dying rates, as well as comorbidities and also our disease processes. And I think we're very well versed in what we're dying from, but we're not as well versed in what the causes of those outcomes are. So when I look at any type of data that represents the causes for our outcomes, especially death, I often think about how that's a kind of an outcome response versus, you know, all of the challenges that led up to that outcome. And so I kind of want to spend a little time talking about those things. And it's beautiful to see how we are really bringing forward this maternal mortality issue for Indigenous women in our communities. I have to say, when I started my career as a nurse 15 years ago, it wasn't a discussion topic. When I became a nurse midwife and realized I was only one of 15 at that time that was Native American in the whole country, this discussion about maternal mortality also was not a topic. And so I went to a lot of conferences and presentations with my colleagues who are nurse midwives and OBs doctors. And again, the discussion around our healthcare as Native women, Indigenous women, wasn't a priority. And so I'm seeing this huge shift happening in the last 10 years where it is becoming a priority, and we're starting to center Native communities and Indigenous women. And so it's nice to have and be part of a conference like this where I get to share some knowledge. It's been a little bit time since I've talked about these things because I've been really heavy and busy in the providing birth services and doing my work as a midwife. So just excuse me if I ramble. I do like to talk about these things. I know I only have 45 minutes, but I will do my best to get as much information in this session as I can. You can do the next slide. Yes, of course, like all presenters, I have to make sure that let you guys know there's no conflict of interest with this presentation and material that's going to be presented today. Next slide. Some of the learning points that we're going to go over, and they're not really specific, they're more like an overview of the discussions we're going to have. Definitely women's health perspective is important. Very brief overview of the state maternal health care in Indigenous communities in Arizona. Some common barriers that Indigenous women experience in accessing maternal health care services. And then, of course, some recommendations for providers and systems to improve access to care for Indigenous populations in Arizona. And then, of course, lastly, resources that Arizona and social service providers should be aware of to support care for Indigenous women. Again, these learning points will just be woven into the discussion and, you know, aren't really specific, but that's the joy of talking about these, this very complex issue of maternal health is there's a lot of barriers and complexity and over interlay of issues. So we'll do our best to, or I'll do my best to try and bring those topics in together. Next slide. I think it's important when we are talking about maternal health issues. I really like to emphasize context when we're talking about Indigenous communities, especially when we're talking about our healthcare. I've read a lot of research about how communication is a really important part of providing services, accessing services, interpreting information, and really knowing that the population that we're serving, especially if it's an Indigenous community, the way Indigenous people think and perceive the world is a lot different than mainstream America does, but also normalizing healthcare that's health-oriented, but also like what are those perspectives when it comes to how we communicate healthcare for women and for our communities, especially with community being Indigenous specific. So I found this actually definition of a feminist perspective. I'm just going to read it. A feminist approach to women's healthcare using a health-oriented normalizing model allows normalcy to be validated. This paradigm enables assessment, diagnosis, and treatment that is woman-centered and that values her standpoint, background, ethnicity, and culture. I think we forget this as clinicians and as, how would I say, as academics, because we spend a lot of time reading the research, talking in spaces where community from who we're serving is not at the table. And so some of these words actually we're so comfortable using that we know what they mean. But when it comes to serving our communities, like there's definitely that language and educational barrier about the context of the language we're using to describe how we're taking care of them and what we're going to do to take care of them. And so I think it's important for anyone taking care of Indigenous communities to do a little bit of work on themselves about what kind of language they use to take care of their communities and understanding that how they communicate does impact on the other side how they're going to perceive that information. Next slide. And here's one Indigenous perspective: to live in a manner that works towards creating and maintaining balance, harmony, beauty, and order. I've traveled all over the world. Like, I've been to Hawaii, I've been to Alaska, Guatemala. I've spent a lot of time with different kinds of traditional healers and medicine people. And it's really interesting to hear how we describe our healthcare, and basically our health and our well-being. And it's not just a physiological thing like blood and blood pressure and bones and blood and those sort of things that we actually think and consider as part of our health. And as far as like our relationship to the universe and our relationship to our communities, like those are all really important. And if you work a lot with Indigenous people, you hear that word relationship said a lot of times. Even as I introduced myself in Dene, I was introducing myself and explaining my relationship to my community. So the dynamics and the importance of relationship in Indigenous communities is actually very important and vital. And it's important that we as clinicians taking care of those communities understand those relationships actually impact our ability to access services, our relationship to our communities, and then our relationship to our bodies and our relationship to the earth. When there is an imbalance in any of those areas, that's what we believe when disease process starts to show up. And so really thinking about how we're going to address these issues that we're talking about, specifically maternal mortality, from that perspective of, you know, where are we out of balance and out of harmony in all of these relationship systems. That is what's causing this outcome right now for our women from dying of preventable causes. And so how do we come together and work in a way that's in a way that's orderly, but also reflects the communities that we're serving? And it takes a little bit of thought to get into that place, but I think sharing this Indigenous perspective and from as being a Dene woman and how I understand it, I definitely feel like it, as I work with my community and I work in community, I have this kind of thinking in mind. Go ahead, next slide. Next slide. Okay. I recently, well, I wouldn't say recently, I would say about 10 years ago, I presented some women's health information in community up north in Hickory, Apache, and it was a room full of their Native women from that community. And I presented to them the topic of health disparities, and they didn't know what that meant. Again, that's another very large term that we as clinicians and academics read about and research and discuss pretty commonly in the things that we read. And so I just put a little definition up here about it being gaps in quality of health that are rooted in poverty, geography, and discrimination. And definitely we're seeing trends not only in Black communities, but Indigenous communities or in communities of color, where these type of things are really playing out, especially now with COVID being an issue in Indian country. That poverty and location and definitely discrimination, that still is happening in our healthcare systems. And I'll talk more about that later, but I think understanding some of these very broad ideas and terms, and then of course narrowing down to what the specific things are is kind of what I'm trying to do right now. And basically weaving this tapestry of information so that we understand the context of which we're working in our communities, and what those issues are. Next slide. So Arizona has 21 federally recognized Indian tribes, and basically 70.8 deaths per 1,000 live births is happening. And I like to show a map of the tribes because people forget, even though you might live in the state, you're not sure where the tribes are. You might drive through reservation and not know it's tribal sovereign land. And these are just some of the stats that I looked up and found as far as pregnancy related deaths. Specifically, of course, it's highest among Black people, but American Indian and Native American women are second highest. And you can see by this map, Navajo Nation takes up a large portion of the state, but there's also smaller nations. And I guess the point I'm trying to make with this slide is basically some of the challenges with addressing maternal mortality in Native communities is each of these nations are sovereign communities. And so they have their own laws, they have their own restrictions, they have their own governing systems. Definitely departments of health kind of interlay with that information, but there's also barriers with collecting information from these communities because it's sovereign communities, sovereign nations, no matter how big or small. Some of these communities might have over 200, 300 tribal members, and some might have thousands of tribal members. But when there is a woman who passes away or dies from a preventable cause and in childbirth or around the time of childbirth, one woman dying in like 60 or 100 community members is actually a pretty large percentage of that community. And so even though in the larger sense, when you see those statistics for the United States, that we have the second highest death rates for Native women in childbirth or maternal mortality, it doesn't do it justice to the context, like the number of people living in a community. Like there aren't thousands of people living in a small tribe. It's like 800, 600, like everybody knows everybody. So for one woman to die in a community of 600, that's like a larger percentage than just what you're seeing on the national average. And so it is very detrimental to our communities when those sort of things happen. Another thing I wanted you to pay attention to in this slide is having access to clean water is an issue in a lot of these communities, as well as access to healthy foods and nutritional foods. There's also areas in this slide or in this image where, like on Navajo Nation, there's uranium mining exposure. That's still an issue. I know there's a study happening. So there's environmental impacts that definitely influence the health and well-being of women in all of these communities. A lot of the poor women have only access to like not the healthiest foods. And what we're seeing in COVID now is definitely families who are not breastfeeding, but are not even having access to formula or clean water. And so the impacts that we're seeing in the maternal mortality rates is location from where these guys are at, as well as access to water and nutritional foods. I mean, those are just backdrop issues. Keep going. Next slide. So I took this slide from the CDC, and as you see, 30%, again, pregnancy-related deaths in the United States, and causes related to lack of access to care, lack of quality access to quality of care, and then prevalence of chronic disease. And then, of course, what I got off there was 60% of pregnancy-related deaths were preventable. And I think I heard earlier there was like 89% of deaths that are preventable. So that really makes you question, like, well, if it's preventable, why is it occurring, right? And I'm thankful for the PREMS reports that actually talk about some of these issues. I know here in New Mexico, and then I was comparing some of that information to what Arizona was experiencing. And something that struck me was that the information was a little bit different, but also some of the issues and what those causes were for these numbers to be so terrible were also very somewhat different. I was reading a report recently, actually, a dissertation that a fellow midwife wrote regarding maternal care provisions in New Mexico and like some of the issues related to what are outcomes like maternal mortality. And one of the issues, again, it continues to be lack of access to care, but we also don't have a very large workforce of educated people working in these rural communities. Not only that, there's very little research that focuses on experience of midwives and doctors working in rural communities and what those issues are. So I think there's a layer of information that's missing from our data that we're just starting to get an understanding of what the causes are. Quality of care continues to be an issue. I've seen this in the research that I've looked at like probably 20 years ago, because at the time the focus of care in Indigenous communities was really, I mean, I find it astounding that the two topics that generally I read about and research when it comes to Indigenous women's health and maternal outcomes is either our really traditional Indigenous practices, which people are very interested in, or our disease process, diabetes, hypertension, STD rates, high risk of teen pregnancy. There's very little information about what women are experiencing as they're trying to access healthcare, and as regards to how if they felt respected, if they felt supported, if their traditional practices were part of that process. And then also thinking about the communities that we're serving. A lot of Native women are primary providers in those homes. Like they might have the one taking grandma to appointments with the only car. You know, they might have 5 children and no babysitter. And I know there's been a huge shift in where women are accessing care and like allowing other children to be present. And that shifted probably in the last 10 years, but there was a time where women were not encouraged to bring their children to appointments. And I know, having worked in an Indian Health Service hospital and been a student training in an Indian Health Service hospital, there was still some stigma around Native women bringing their children to appointments, even though it wasn't frowned on, but it also wasn't supported. And so I feel like that's a quality care issue, because if we're going to take care of women, especially Indigenous women, where family and community is important, and we don't have support with daycare or another health person who can take care of our children, we do need to make those spaces more comfortable and accessible for women with children. And then, of course, the prevalence of chronic disease. We know we have a sick population. You know, diabetes, as I mentioned, hypertension is an issue. Drug addiction and abuse are issues, as well as, you know, some of the other kinds of things like cancer and those sort of issues definitely play a part in causes of death that we're seeing in our moms in Native American communities. I would like to also include in there the lack of access to care in the first trimester is really important, because there's this underlay of chronic disease contributing to our outcomes. It's important to, again, understand our population that we're serving, but also be fully aware of these underlying chronic health issues that will impact the delivery and the prenatal care, and of course the outcome. As far as community goes, you know, we're seeing this, how would I say, missing murdered Indigenous women issue kind of is I wouldn't say an emerging issue, but it's coming into focus. And when I think about that, I think about common causes of death for Indigenous women across the board, and not just pregnant mothers, and how lack of community is a contributing factor to that. A lot of these women don't have support systems, and there's a lot of mental health issues, PTSD and trauma, that contribute to a woman's ability to comprehend information that you're explaining to her, to feel safe and supported by her healthcare team, as well as feeling like she can trust those that she's going to care for. And when she doesn't have a community of support, like, it makes it even more challenging for her to access care. Healthcare facilities, again, there's limited depending on location. In Arizona, they're in different places, but that's a contributing factor. Providers and systems, a lot of people providing care to Indigenous families are non-Indigenous. And so there's a lot of education that needs to happen before they can go into community and take care of them. But also understanding that there's also internal bias and historical knowledge that's missing from people who are providing services in community who are just getting there. And I know there's, you know, I've been in places where cultural competency is a discussion where you get like a day or two to talk about what's happening in community, or like you talk about culture and like what are the norms in that community and things to pay attention to, but really that's not enough. I think there should definitely be more work being done to educate people from other communities coming into communities of Indigenous communities to provide services and care. Systems are a huge contributing factor to when I see these preventable causes of death for Indigenous women, because our systems are primarily supported by government funding, and a lot of our services are through Indian Health Services. There are limitations and guidelines on how those services can be provided, but also take that off. How that funding can be used, who's considered part of the team, those sort of things contribute also to these outcomes, because I feel like there's a large population of people that we're missing out who could be part of the team and part of the workforce to address these issues. And you know, each hospital, and maybe you don't know, but having worked at different places, each hospital system has their own politics and culture that definitely contribute to how Indigenous communities are treated and how women are treated. I mean, even recently there was Loveless Hospital here in Albuquerque was in the news because they were discriminating against Native women. It was internal policy that they would separate their moms and their babies if their COVID test wasn't back after delivery. And I know that was a recommendation for a little bit through like the American College of Pediatrics, and then they changed their stance. But these sort of policies coming from outside and in communities where family and community are really priorities and part of the ecosystem of health and support and contribute to better outcomes for moms. No, it's this one. That's it. They actually make it worse for communities rather than better. And so I feel like it's really important for these type of things to come from community about how we're going to serve community in a better way. Next slide. Some of the things that that I've seen providing services outside of the system, and definitely I see lots of Indigenous women having issues with, is no insurance card at the time of prenatal visits. So there's a large number of Indigenous women who don't access care in the first trimester, and that actually is, I believe, a PRAMS measure to see how healthy the population is. And basically, you know, private payer insurances or private healthcare clinics usually require women to have insurance card at the time of prenatal visit. Now, if they're Indigenous women and they're going to an IHS facility, maybe that's not such an issue. But if you work in Indigenous community long enough, you recognize like people travel. Native people don't stay in their community and live in communities and like grow up there. Like a lot of them travel to like other places, and so if they don't have an insurance card or there is an insurance expansion to capture those people who are not in their service area, they do end up missing out and getting services because of where they're living at the time. Lack of transportation continues to be an issue for, I think, anyone living in rural community. As I mentioned, most Native women or families might have one working vehicle, or I'm seeing actually a large, in our practice, I'm seeing more Native women in their probably 18 to 25 who don't even have a driver's license. And so that, I think that is definitely leading to the lack of transportation. And also, if you think about women who are living in abusive situations where their partner has the vehicle, may not be able to get to an appointment. The third topic is not enough education about why accessing prenatal care in the first trimester is necessary and important. I think what I hear from a lot of Indigenous women when they come to me for care as a midwife is a lot of things are not explained to them. There aren't any campaigns with departments of health around why accessing prenatal care in the first trimester is important. And just a little bit of midwifery and women's health knowledge is, you know, those first 3 months of pregnancy where the placenta is forming, the brain is forming, the limbs are forming, like all the vital organs necessary for survival are forming. And so if there's any exposure to teratogens, medications that they shouldn't be taking because they have an underlying health condition that could be detrimental to their baby's health, undiagnosed and uncontrolled diabetes, those all affect and have stronger impact in that woman's health and that baby's well-being those first 3 months. And so for them to get into care for that first prenatal visit is actually really important, because you can get an ultrasound to make sure that the baby is actually in the uterus. You can get blood work to make sure that, you know, her diabetes, if she has it, it's either diagnosed or it's controlled, or you can send her to the appropriate people to take care of these high-risk issues that are emerging or maybe not exposed yet. Nutrition is also a really important thing that I feel like is not really even addressed in prenatal appointments, especially when I was working in a busy clinic and I was seeing 20 people a day. Nutrition is absolutely vital to blood volume and to the placenta growth, and a lot of these things that we're seeing down the road, that nutrition could actually make a really good impact in decreasing those issues as far as diabetes and large for size babies, which we do see in Indigenous communities. But we're missing that window of time when women don't go to their first prenatal appointment, because they're missing all those opportunities to screen for these issues and to have a healthier pregnancy. Again, contributing factors to these issues where women are not accessing care is, again, lack of Indigenous providers from community. The benefit of having an Indigenous person from their own community serving their own community is they're aware of the politics and community. They're aware of the nuances and challenges their community faces when it comes to healthcare and services. They are also aware of the historical context of this facility or service in communities specifically, and I'm talking about Indian Health Services, because even though they've changed over the years and are moving towards more of an equitable healthcare model, there still is a very long history of obstetrical reproductive violence and abuse. And so communities still, those stories are still there. And so Indigenous providers are aware of this and have to walk that line oftentimes, where if they work for that institution, they can be seen as part of the problem versus part of the healing that needs to happen. And so having an Indigenous provider from community working in a system where they are fully aware of what's going on in community, but also has their foot in the politics and the healthcare systems, can give and be that communication bridge between each, so that the systems or the hospitals and the clinics in place actually know and can provide better service to the community with having that person in there. I want to say internalized bias is also really important to recognize, and many of us have it, even I do. It doesn't matter what color you are, but if you're serving in Indigenous communities, it's important to do that work and recognize what that is and how it's impacting your ability to give information that's unbiased. And I think that's important, especially as a healthcare provider, because we do read a lot of research and we have our own ideas about how we feel information is important or not information. You know, and what I'm seeing is certain even devices being pushed in communities because they're marginalized, because they have higher rates of teen pregnancy. One of them would be IUDs insertions after delivery. Another one might be STD screening, like this full spectrum of screening for all people, regardless of where they're from. It's just becoming policy in that institution to do these things. Drug screening, again, is another one. And so when those sort of things are put into place, you actually further disenfranchise that community, because you don't give them the opportunity to be educated about the issue, or even to give consent for any of these things that you're doing to them. We just assume that we're supposed to do them because they're recommended to us by ACOG or ACNM or whoever is overseeing some of these policies enacted in hospitals. Institutional racism is also still pretty prevalent in our hospitals and our communities. As I mentioned, the spaces are not exactly supportive of Native Indigenous women bringing their children with them. You have providers from other communities that are non-Indigenous who might see this young person having multiple babies as something negative, and might come into that space with that thinking that you need to educate them on STDs or on birth control, where this woman is coming into that space wondering why you're talking to her about birth control when she wasn't ready to talk about it. And so it's understanding like that part in the institutional racism that does play a part in why accessing care for this specific population continues to be a challenge. Complex healthcare systems is a huge issue. And I usually can't go into that too much because I end up talking about policies and historical issues that have made our system the way it is. And because Indigenous women's health, Indigenous health is very complex because of the funding structure and even the sovereignty issues in tribal communities, like that all adds to, you know, where does the funding source come? Do they have health insurance? Can they stay in their service area? How do they know how to navigate this healthcare system when they're not even really understanding how it works? And I find that often even for us at Change Room Initiative, when we're providing services on Navajo Nation, trying to take care of a family who got primary care through Indian Health Services, but because of the way their system is set up, it's a closed system. And being able to order labs and ultrasounds outside of that system, knowing that those things will not be honored in Indian Health Services because I don't work for them and I work outside of them, that's a barrier for this family, it's a barrier for me, and that's a barrier for any other outside healthcare system trying to come and establish services in that area. And so having a very good understanding about how these systems work so you know how to navigate them with these families, I think is also a contributing factor to this outcome that we're seeing. Next slide. So these are some recommendations that I came up with in regards to improving care. I know innovation is such a broad term, right? And because many of us are very well versed in institutional healthcare systems, policy, some of us, and of course, some of us from the communities that we come from, we're really comfortable navigating those systems. But it's really key to keep all of those things in mind when you're creating or trying to create something that's innovative based on what the problem is. And really that's where and how Changing Woman Initiative came about, is from my knowledge of these systems in place and then reading the research and being aware what the challenges and barriers are, and then coming up with ways to fill in those gaps that we were seeing. And I feel like with this new emerging information, and it's getting worse with the maternal mortality rates increasing, we're just getting a sense of like, yes, there's a problem, but like, where is those barriers presenting themselves? You know, where are the system barriers? Where are the community barriers? And then also now we're going to be in a point of like, okay, how do we fill those gaps? You know, is there policy changes that need to happen? Is it as simple as just getting food to people's table and food is the issue? And thinking outside of that box, right? That it's not just within the facility and institution that we work in that this innovation needs to happen. It actually is a larger ecosystem than most people think. And it's not just going to happen in this like vortex of like where we're comfortable. And I think being able to pull information that we are aware of and know and knowledgeable about to create something new based on what we're seeing is important and necessary, and that's the direction we really need to go. Knowing your community is super important, because many of us I'm Navajo, I live in San Ildefonso Pueblo. Being aware of the politics and community is really important because there are stakeholders in community who have sway with the political people and with the women. Having an in with them is really important, necessary to push any initiative forward. And that's that community work. And I feel, and it's unfortunate sometimes that we get so caught up in the facilities and the institutions that we work for that we lose touch with that community piece. And we really need not to do that because they're the other partner that we really should be inviting to the tables where we're discussing their communities and how to serve them best. And recognizing that those community stakeholders don't all have master's degree or bachelor's degree or nurses. You know, yes, some of them are community health workers, but some of them are also elders and women who often will show up to community events. So it's again looking outside of that institutional educational framework that we're so used to, and looking at really who these key people could be in community to help push the work forward and to make those changes. Being aware the funding dictates how and where we care is provided. So I know a lot of the funding that's been received around maternal health is government funded, HRSA funding. Anybody who's written a grant for HRSA knows it's a very complex, tedious process. But then you get into the realm of like how that funding can be used, keeping track of that funding for accountability to the funder who gave it to you. Like a lot of that is a lot of work, and usually it requires a large team of people to make sure all those things run well. But if a lot of our funding's coming from government or coming from these places that dictate who it can be used and how it can be used, that is a real limitation from trying to be innovative and think outside the box and to serve community how we see they should be served. And I don't know if that's ever going to change unless there's people in those positions that understand the funding is actually a real barrier. It's not so much lack of funding, but the oversight and where and who can be funded is the barrier. And I would like to say like indigenizing funding is really necessary, because we often run into that with our financial stuff for Change Home Initiative. Like we wanted to fundraise with doing like a powwow, but I'm like, how do we account for the food and the facility and our QuickBooks? Like, I mean, it doesn't always translate when it comes to the financial part, especially when it comes to serving communities, Indigenous communities. Recognizing community members as experts and providing training to lay community members so they become a resource in the community. Whew, there's a lot to say. I really believe in training community people to be experts. I mean, they already are experts because they know how to navigate their community politics. If you think back to some of the things that were pushed in our community, whether it's breastfeeding or having healthy families, or you think about the role Indigenous women play in their communities, you know, our grandmothers, our aunties, like they all have a very important role to play in our community. But imagine giving them more skills, you know, breastfeeding support, peer counselor support, doula training education, nutritional training education, plant medicine traditional education, all of these things that you could actually be training the community to learn to take care of each other, versus, you know, spending so much money and time training one healthcare professional to serve that community, and instead empowering the community and treating all of them. I think that's important, and that's something that we are doing with our organization, because when we hosted a doula training in Window-Rock last year, like we had like 50, we actually had 100 applicants and we could only take 30, but they were so hungry for that information and wanting to serve their community and provide services for women in hospitals and in home settings that we just didn't have the capacity to train them all. So I think you're going to find a very hungry community for information if you provide that funding and that space to actually provide services, training like that for them. I think it's important to think outside of think of the larger picture, that it's not just the facility, but like the community as far as improving healthcare, including traditional healers, including birth attendants, are also valid members of the team. Because again, historically, we've always relied on traditional healers. You know, our aunties were the doulas, our grandmothers were usually the one having the babies or supporting birth in the homes. Like there's this whole traditional Indigenous system already in place that's been there before we even came here. And so I think it's important to do that work, to include them as part of the team instead of, you know, drawing a line in the sand that they are not included in that picture, because they are. The last point is human rights in childbirth. I want to say that Indigenous women and any birthing person they're very powerful in pregnancy, but they're also very vulnerable in labor and hospital settings. There's a lot of emphasis and trust put in your midwife and your doctor and your team of providers taking care of you. So they don't always know if information is being withheld. They don't know if they can or can't get out of bed. You know, they're really relying on the institution to tell them what to do. And really that's what displaces them from their place of power when they're in a place like that, that is outside of their community and outside of their families. And that's what puts them in this place of vulnerability. And so human rights in childbirth is not an emerging issue. It's always been an issue. There isn't a lot of research, again, around women, especially Indigenous women's birthing experiences, around whether they felt respected or supported. And I'm questioning why we not asked that question yet. You know, it's because who's doing the research? You don't see Indigenous people asking these questions. And I don't see white and non-Indigenous researchers asking these questions because they're more interested in like our traditional practices and our STD rates versus are we serving Indigenous women in a way that they feel supported and respected. From our perspective, it might be yes, but from their perspective, it might be no. But is there a way to measure that? Next slide. Let's see. So thinking outside of the box, let's see. Here we are. What other resources do Indigenous Native American clients' families need when you take care of them? I saw this slide when I was looking up some information, and it was really astounding to see that a large population of women died from hemorrhage, cardiac hypertension and disorders, especially suicide, homicide, and accidents. And thinking about even the women that Change Women Initiative takes care of, you know, oftentimes I find myself trying to find a lawyer to support a woman who's in an abusive relationship trying to leave it. She's having issues with trying to get access to foods that are healthy. And because there's this underlay and backdrop of trauma and violence and PTSD, a lot of them don't have access to counseling and they need counseling. There's a limited amount of Indigenous doula collectives taking care of Indigenous women in hospital settings. And again, because of COVID, we don't see, there's even another barrier, right? Like they can't have all these people in the hospital with them. But there are Indigenous doula collectives. I know there's one there in Phoenix that serves Indigenous communities. But, you know, having those type of things available to women, especially in rural, more outlying places, is necessary and needed. Transportation services continues to be an issue and it is needed. Domestic abuse counselors, safe homes. Again, it's interesting, once a woman is pregnant, it makes it a little even more challenging for her, not only to get placed in a safe place for herself and her unborn child, but if she has a drug addiction or is needing treatment to be withdrawn from drugs, there are very limited places she can go as a pregnant person. And so these are some of the things that Indigenous communities absolutely need and don't have in place. And I believe if we get these things in place to support them like a cocoon in this ecosystem, we will see a shift and change in those outcomes that we're seeing right now. Next slide. So I just want to say with my last remarks here, and I don't know if we're at 45 minutes, oh, we're about there. One of the most important things that I found in looking at New Mexico and then of course Arizona is there's definitely differences in causes for maternal mortality rates in Native American birthing families, and that we can't look at this issue in Indigenous communities as like this like overlay of like broader issue. Like each state's issues are different, and I think it's important to acknowledge that. There's a lot of health policies passed by non-Indigenous folks that know very little about our communities, and this actually contributes to increased mortality rates in our communities. I spent a lot of time talking to legislators and policymakers, as well as my state representatives and my organizational ACNM, ACOG representatives, to explain our healthcare system to them, to explain our communities to them. And it takes a lot of work for me to do that, but I'm thinking, how can these people be making policy changes for us when they don't even know what our healthcare, like what our community is, when they don't understand our funding and our history and how that relationship we have with the government. And so I think it's important when we talk about health policy and the changes we want to see, that that is a contributing factor to our outcomes, but that's also an area that needs to change and be improved. And then the last point is to think about how our current healthcare systems that we created do a disservice to Native American birthing families, and how can you support institutional changes where Native women people can't be at the table to advocate for themselves. Me, who having worked in the hospital setting, I've been at these tables where the birth mom was discussed and the neonatologist was there, the OB doctor was there, the pediatrician was there, the hospitalist was there. Like all these healthcare professionals were at the table to talk about this woman and her birth, whether she could take her baby home or whether she could breastfeed, or marijuana was an issue, but she wasn't at the table. And so if you're an Indigenous person or if you're serving these communities, you know, coming to those spaces, not just with your degree and with your medical knowledge, but with your community hat and with your voice to uplift this person who isn't at that table. And when we leave those communities out of the discussion, that's when we do a disservice to these families, because they can't be at that table advocating for themselves. You don't know what those circumstances are. And that's all I have to say. I think, is that my last, I have one more slide. Next slide. Okay. Yep, I think that's it. I think I have a question.
So Nicole, thank you. This is Natalie, and I will, we have time for about 2 questions, although we're going to ask you for answers to more than 2 questions, so that we can communicate that later to our participants. So the first question is, as a home nurse visitor, what can we do to help lower the 60% preventable deaths?
Cool. Well, the benefit of home nursing is that they get to see their, like the person's home, they're in community. So they're vital to providing information to the providers in the hospital and the policymakers. And so, and that's a very broad question, but really providing services in the home is something not everybody gets to do. It's a privilege to be in somebody's home to do that. And I think by continuing to advocate for families by what you're seeing in that space, I really encourage any nurse who's been working in a home setting like that to actually become a nurse practitioner, a nurse midwife, or some other level provider, because unfortunately, as I found, because I was a nurse for so many years, is nurses are definitely very helpful in providing information, but the decision making around how this person is going to get care isn't always in our hands. And I think that's why I chose to be a midwife, is because I saw things happening, but I didn't have a lot of control in changing them. I believe if you get more involved in community activities, policy work, so that those issues are what you're seeing gets heard, you know, I think that's where you can make the most impact and change. And you had a very broad question. I don't know if I answered it well, but that's one answer.
All right. The next question is, it sounds like dissemination of information regarding the first trimester is needed. Are there existing public efforts being done in Indigenous communities in Arizona or in the state in general?
I haven't seen that. I haven't seen that big push to get people in for the first trimester.
Okay. And then we have time for another quick question, which is, are there centering pregnancy groups for Native women?
It depends on the location. There's some challenges with centering pregnancy in Indigenous community. One challenge would be maybe one woman has, or 2 women in that group could have the same father. So it becomes an issue of like feeling safe to talk about personal issues in that space. I see a lot of Native women who travel long distance for care. One is because they want to come see us. 2 is because they want their privacy. And so sometimes being in a centering pregnancy setting with other Indigenous women from the same community poses a risk of privacy for this woman or this individual. I know in Arizona, I mean, in like Alaska, and then there's, I think in Albuquerque, there was some centering pregnancy and it was successful, but that's what they reported, is that it could be challenging as far as privacy goes.
All right. Thank you, Nicole, so much for sharing such valuable information to everyone on our summit today. And as they've said in the chat box, it's always nice to have you here with such valuable information.
Yeah, thank you.
So we will be going to a break here in a moment. While we're on break, there'll be a lovely yoga video playing so that if you'd like to get back in touch with Desiree's blessing, we can absolutely do that. And we'll be starting promptly at 11:10. So you have 10 minutes to go stretch your legs. Again, grab coffee, tea, water, whatever is your beverage of choice. Stretch a little bit, move around, and we will be back at 11:10. So enjoy the brief yoga video that we have. If you were on our SEND training, you will have experienced some of this on breaks. So thank you, everyone, and we will be back at 11:10. 11:10.
Hi everyone, thanks for joining me today. So today we're going to work on a neck and shoulder releasing sequence. It's quite short, it'll only be about 10 minutes. And you can do this either sitting on a mat, or if you're in your office or you prefer to sit on a chair, please feel free to grab a chair. So let's just start in our comfortable seated position, resting the hands lightly on the thighs, and just close down your eyes. Just taking the first few moments just to draw your attention inwards. Starting to focus on your breath. Taking a few slow, deep breaths. Slightly scanning through the body. Notice if you're holding tension anywhere. Just see if you can just soften into that part of the body, particularly on the exhale. Feeling some length through your spine, all the way up through the lower back, middle back, upper back, through the neck and right up through the crown of the head. And then let's open the eyes. Bring the arms down by your side, and we'll just start by circling the shoulders forward and back. So nice big circles. Notice how your shoulders are feeling. For a lot of us, they can feel just a little bit crunchy. We tend to hold a lot of stress in our shoulders. And keep your breath going here as well. And let's change direction, so going just back and forward. Just a few more like this. Try to breathe into your shoulder area.
Welcome back, everyone, from your break. Now, the yoga video, in all fairness, we sprung that on our AV team at the very last minute, but hopefully you were able to enjoy a few minutes of the breathing or stretch on your own just to get ready for our last segment. Now, remember, for CEUs, you need 3 keywords. We gave the first one to you earlier this morning. The second keyword, are you ready? The second keyword is my favorite color, purple. P-U-R-P-L-E, your second keyword for CEUs is purple. So I'm going to introduce you to our panelists. They're the last 3 speakers for today, and the panel is entitled Reducing Risks and Barriers for Arizona Women: Perinatal Mood and Anxiety Disorders, Substance Use, and Intimate Partner Violence. We have 3 panelists with us today. Michelle Lacey, who's with Women's Health Innovations of Arizona. She will speak to us about perinatal mood disorders. Secondly, Dr. Maria Manriquez, who is with the University of Arizona College of Medicine in Phoenix, who will talk to us about substance use, treatment, and prevention. Lachey Brown from the Arizona Coalition to End Sexual and Domestic Violence will talk to us about domestic violence before, during, and after pregnancy. So I will introduce them one at a time before they speak. And then at the end of all three presentations, we will take your questions. So remember, the Q&A box is for those questions. We will do our best to ask them in the time that we have allotted. And if we don't get to them, then we will do our best to get you answers after the summit, or in the chat box. Some of them are also being answered. Our first panelist will be Michelle Lacey, who is the Executive Director for Women's Health Innovations of Arizona, also known as WHI. She's a licensed outpatient. It's a licensed outpatient treatment center and nonprofit specializing in maternal mental health care. Michelle is the founding member of WHI and has worked to grow the organization to meet the needs of moms and families in the perinatal time. She has been a member of Postpartum Support International, or PSI, for which she serves as a trainer, is a subject matter expert, a state coordinator, and the board president for PSI's Arizona chapter. I'd like to remind you, if you have questions, again, use the chat box. If you haven't added your name from the beginning of our summit to the chat box, first and last, then we will, you'll need to do that for CEU. So again, Q&A goes in the questions for our panelists go in the Q&A box. And again, if you got it, second word, purple. So now that we have all the housekeeping done, Michelle, please welcome Michelle to the stage.
Thank you so much for having me today. I want to take a moment to just express my gratitude, because maternal mental health disorders is my true passion, and I love to educate so that everyone has accurate information, because there's a lot of misconceptions and preconceptions about what maternal mental health actually looks like. And as a result, that in itself is a barrier for women to receive treatment. And it's not just about depression. There's a spectrum of issues, and I will touch on each of those, but this is not just a woman's issue. We know that untreated maternal mental health disorders have an impact on the entire family. So it's a family issue. The lack of care and specialized care is a community issue, and as a result, I believe it's a public health issue. So, disclosures, I have no conflicts of interest of anything I'm doing today. So the perinatal period, we refer to any time during pregnancy and in the postpartum, first year postpartum. We have a lot of misunderstandings that, after 6 weeks, a mom will be fine, back on her feet and heading forward. But actually, a mood struggle can occur any time in that first year postpartum, and weaning from breastfeeding can also trigger a mood disorder. We know that maternal mental health disorders are the #1 complication of pregnancy, yet we do not have universal screening for it. It's not paid for. And we know too, with proper care and specialized care, women get well. And so why I'm here today is to help, let's begin to break down the barriers of getting that specialized care. ACOG identified that 1 in 7 women will experience a maternal mental health disorder. But in 2013, there was a large study of 10,000 women that showed that 21% of women would struggle with postpartum depression in that first year of postpartum. We also know women in poverty will experience a perinatal mood and anxiety disorder at 50%, 1 in 2 women. And more recently, with COVID, a preprint study is coming out of 600 women that indicated about 1 in 3. And we see this clinically in that there's the restrictions in hospitals, there's lack of support, maybe moms laboring and delivering alone, being separated from their baby if there's questions about COVID. And so there's a lot of trauma as a result of those restrictions. We also know that 1 in 10 dads can experience a postpartum depression. What we often know, though, is that dads will not likely get help, and they tend to be more angry. They tend to withdraw. And so what we know is that the first year postpartum has like the highest divorce rate than any other time in pregnancy, which affects the entire system. Well, dads tend to withdraw some, and some of the research shows that untreated paternal depression has a direct link to increase in spanking, less likely to read with baby or children, and to withdraw. So what does it look like? So we often hear people say, baby blues, I had the blues. And when we ask to clarify, what we get is, oh, it lasted for 4 months. Well, that's not the blues. The blues is something that occurs in the first few weeks postpartum. It's about 80% of women will experience this. And it's something that occurs as a result of the significant hormone drop. If you think about in pregnancy, hormones, progesterone and estrogen are increasing. And I have had some OBGYNs and some midwives share with me that it's like going from taking 100 birth control pills a day to the third day taking 0. Can you imagine what that impact has on our mood and our chemistry? And so the baby blues is that roller coaster of emotions, and then it tends to mellow out. If it goes beyond that 2 weeks, what we can see is perinatal depression. And depression can occur in pregnancy and in postpartum for about 20% of women, like I said. Suicidal thoughts and suicidal ideation are a symptom of depression. And as Nicole Gonzalez had mentioned, the issue of shame, many women who struggle with a perinatal mood disorder struggle with a deep sense of shame. There's myths of motherhood that this should be happy, glowing time, and we should be able to do all of this and do it well and with a smile on our face. So when I am struggling, then what is wrong with me? I turn inward. We can have perinatal anxiety with or without panic. And anxiety can be so overwhelming and it robs women of their joy. So there can be a high rate of co-occurring depression with the anxiety. But these are moms who can't sit still. They may come to their labor and delivery with a 50-page birth plan. They may they describe it as having 50 browsers open at once and not being able to focus on one thing. They tend to move into the what ifs, or all the horrible things that can occur if I don't get it right. Very black and white thinking. The panic, if a woman has not had a panic attack in the past, she can experience it from a dead sleep. So can you imagine what that must be like for her? And because of all the misinformation that's out there, she might believe that she's going crazy. You can have postpartum OCD or perinatal OCD that looks like these intrusive, horrific images going through your mind like a movie playing out of all the awful things that can happen to your baby. And moms feel so overwhelmed and they're horrified by these thoughts, and they tend to keep it to themselves. In fact, there's a 65% rate of co-occurring depression for moms with OCD. It's the most misunderstood and undertreated disorder in the perinatal period. And moms that have these intrusive thoughts are not going to harm their babies, but they're more at the risk of harming themselves because of the horror of those thoughts coming through. This right here is why there's a need for specialized care, because very well-meaning people have said things like, don't tell anybody, or else your kids are going to be taken away, or it's been misunderstood and thought of about that it's postpartum psychosis, which is a medical emergency. You can have trauma arise with pregnancy and postpartum, 2 avenues of that, which is if a mom has a previous trauma of sexual trauma or physical trauma, all of that can come up to the surface when she's pregnant or postpartum. But also you can have PTSD if there's any kind of interventions in the labor or the delivery, or even in the NICU. Moms in the NICU have a high rate of PTSD. And unfortunately, not many people are seeing it from that lens of trauma. And so behaviors of trauma like withdrawing or numbing or aggressiveness or poor concentration are misinterpreted as they don't care. they don't want to be involved, or gosh, they're rude, or they're nasty. And I always think, what is it possible that they're traumatized? So I never ask a woman, just because she had a healthy baby, a healthy outcome, I never ask her say how wonderful that is. I asked her what she thought about her pregnancy, because trauma is in the eye of the beholder. And moms, I cannot begin to tell you, many women who struggle with sexual trauma, have had sexual trauma, begin to reprocess their trauma in the perinatal period. How hard is that while you're just adjusting to motherhood? You can also have perinatal bipolar disorder, and the DSM is indicated with bipolar disorder with peripartum onset. And what's striking is that 50% of women are diagnosed in the postpartum period with bipolar disorder. And postpartum psychosis is a medical emergency. And the reason why we want to understand bipolar disorder is because women with bipolar disorder have a high risk of postpartum psychosis. And postpartum psychosis is a medical emergency. We have a 5% suicide rate and a 4% infanticide rate. This is when the tragedies happen. And what I think is important to recognize that so many women do not get the help that they need. So then the depression, the co-occurring depression, can bring them down. So that takes me to my next slide, which is, of all cases of perinatal depression and everything that goes with it, only 60% are detected and diagnosed, and of those, only 40% of women receive any treatment, which is horrifying to me. We know who is at risk. We know what works. We know how to treat it. That should be much higher. And we know that pediatricians, less than 46% are screening. Now, I understand why, because the question is, once I screen, what do I do with them? Which is why it is a public health issue and a community issue, in my opinion. We know the risk factors, and I want to point out that a risk of suicide, of untreated depression in pregnancy, is pretty significant for those women. They have a high risk of depression in the postpartum, and also poor self-care, poor nutrition, poor sleep, increase in drug and alcohol abuse, exposures to the baby. And this brings the snowball effect of stressors that can occur for a woman or for that infant. So we need to address the mental health needs. In the postpartum, we see a slew of consequences of the untreated illness. As I said, relationship problems, poor adherence of medical care, and exacerbation of medical conditions. So moms may tend to ignore those things, which increase her risks as well. Increased risks of intimate partner violence, and I can't wait to hear about your conversation about that. Separation, divorce, which has all these psychosocial consequences on the family. Losses related to interpersonal relationships and finances. We see a higher incidence of disability and unemployment, and a risk of child neglect and abuse, which is significant. The other piece of it is untreated maternal depression and anxiety and mood disorders has a direct link to a child's future cognitive, behavioral development and emotional development. So we need to, it's not just a woman's issue here. There's also increased risk of tobacco and alcohol use, and then infanticide, homicide, and suicide are the risk factors of an untreated illness. We also know that it can become a chronic mental health issue if it goes untreated. We also know it costs a lot to keep it untreated. In 2017, of all births in the United States, $14.2 billion were spent on the untreated illness, and they focused a lot on the multi-generational consequences of the untreated illness. So we are creating a mess by not treating it. We can, if to the core of it, we can have an impact on so many levels and so many generations. We know the risk factors, and I'm not going to go over all of these, but there are a lot of risk factors that people aren't aware of. People think, well, I don't want to kill my baby, so I must not be, I don't want to kill my baby, and I'm not at risk for this perinatal mood disorder, so I'm good. But I think if we can educate of the risk factors, then we empower women and families to do something about it, to put systems in place to prevent. So Postpartum Support International recommends screening for, I think, screening, and ACOG, everyone has their recommendations. But PSI, which is sort of the organization that sets the standard of care for perinatal mental health, has recommended screening often in the first and second trimester, 6 weeks postpartum, 6 or 12 months at the OB and primary care settings. So everybody should be, anyone that comes in contact with this mom should be screening. And then we as a state need to put a system in place so that when they screen, they have a place to send them. There are validated tools, and the Edinburgh is the most highly used. It's 10 questions. It identifies risk. It's not a diagnosis. It's an opportunity to educate. It's an opportunity to normalize, and it's an opportunity to identify those who need further help and support. We know that screening works. We know that it decreases the prevalence and increases the rate of remission and treatment response. It increases and it decreases the period of suffering for that mom and that family. So it works. We need to get some universal screening going. There's some resources available for you. We offer Zoom links, Zoom virtual groups. We have groups 5 days a week in our partnerships. And the Arizona Support International has an Arizona chapter. There's a statewide warm line, and it's manned by trained volunteers. So there are resources out there. I think I got my 15 minutes in. Thank you.
Thank you very much, Michelle. And just a quick comment before I introduce Dr. Manriquez. Thank you for everyone who is using the chat box in, the Q&A box. I keep saying chat box, the Q&A box for our panelists. This is where you'll put questions. Since we have 3 panelists, if you would please note if you have a specific question to be directed towards someone, please note their name in your question. So again, Q&A box for questions for our panelists. It is my pleasure to introduce Dr. Maria Manriquez of the University of Arizona College of Medicine, alumnus and professor in the Department of Obstetrics and Gynecology at the University of Arizona College of Medicine in Phoenix. Dr. Manriquez brings vast experience in program direction that spans undergraduate education, medical education, graduate and continued medical education. Her American College of Obstetricians and Gynecologists service includes Vice Chair and Chair of the Arizona section of ACOG. She has served as at-large fellow for District 8 on the Advisory Council for ACOG. Dr. Manriquez served on the Council of Resident Education and Gynecology and as CREOG Program Chair. Dr. Manriquez continues to maintain a clinical practice focusing on substance use disorders and pregnancy. Currently, she runs the Pregnant and Parent Women with Substance Use Disorder Center at Banner University Medical Center, Phoenix Women's Institute. Maria? Maria, you're muted.
There we go. All right. I had it at the bottom of the panel initially, and then when I started my slides, it changed. Okay, can you guys hear me? Yep, great. First, I want to thank the committee for inviting me to speak, and I want to just congratulate all the previous speakers, and I'm excited to listen to Leslie later. This is just such a wonderful opportunity that we can share our knowledge and share our experience and also be able to share what we're doing, the exciting stuff that we're doing as a state and just general individuals trying to make things better for moms in the mortality and morbidity arena. So I'm going to start this presentation, and like Natalie said, primarily most of my clinical work today is around substance use disorder in pregnancy and parenting women. I have no financial conflicts. And the learning objectives today will just be to learn about the risks and impacts of substance use disorder before, during, and after pregnancy, learn common barriers to substance use treatment during the prenatal period, learn some recommendations for providers, and then some community resources as well that are available. Just a little bit about epidemiology of substance use in pregnancy. We know that alcohol, nicotine, and illicit drug use is present, and these are approximate percentages of the use during pregnancy. From 2000 to 2009, antepartum maternal opioid use was known to be increased from 1 to 5, so a 5-fold increase, and probably maxed at about 6 to 8% when we really started becoming quite aggressive on the education and awareness of opioid use that was occurring. I remember when I started medicine a long time ago, you never really gave a pregnant patient a narcotic. And just before probably 2012, 2013, I noticed that everybody was giving pregnant patients narcotics for pretty benign reasons. So you knew something was coming, and certainly, of course, it was. In 4 to almost 5% of pregnant women will report having used illicit substances in the past month. This is probably approaching 8 to 10% for alcohol use disorder. So it's important, especially prior to pregnancy, if they're not anticipating getting pregnant. Sometimes substance use disorder is a part of the pregnancy and how pregnancy came to be about, an unplanned pregnancy in particular, not necessarily unwanted, but unplanned. 1 in 300 women will become dependent on opioids after a cesarean section. That's a pretty significant number if we think about it. And then neonatal abstinence syndrome and or neonatal opioid withdrawal system, it cost our system about $1.5 billion in 2015. Substance use disorder is, and pregnancy, we're talking a lot about mortality today, but it's important to appreciate that in Texas, Maryland, and Arkansas, 17, 15, and 22% respectively were associated secondary to substance use disorder. So objective number 1, list appropriate screening tools to identify substance use disorder in our patients. We want to be real careful to avoid bias. We all have unconscious bias, and hopefully we bring our unconscious bias to consciousness, and then we learn strategies to mitigate the biases. And so we want to be careful to make sure that we screen appropriately. We repeat our screening, as Michelle said. We want to screen at the initial visit and each trimester and postpartum. And essentially, my mantra with my students and medical residents are screen every patient every time. And if you're doing that, you're not going to miss screening anyone. And it really eliminates the biases that we may have, and many of us may not be appreciative of. Biological drug screening, urine, blood, saliva, they're done in certain circumstances. By and large, universal screening is a screening tool, a verbal screening tool. You should always have consent if you're using biological drug screening. We want to normalize screening. We want to communicate to our patients that this is what I do for every single patient, and this is just part of the counseling and education that goes into the services that I give you. Screening versus diagnosis, it's very important. You may have a positive screening tool and you may have a positive biological test, but unless it's been confirmed, these are screening tools, and they're all dependent on their sensitivity and specificity. So it's important to appreciate that as a clinician, but also to help your patients understand this, this issue as well. So when to do biological testing? Ideally with patient's consent, as I said before, and with ACOG, as well as probably many state regulations, should be done in an outpatient setting. In an inpatient setting, particularly when there's an emergency, you may be able to biologically test urine, blood, or otherwise without consent. And so for an attended patient or unconscious patient who presents delivering with no prenatal care at delivery, physical evidence of track marks, unexplained soft tissue infections or endocarditis in particular, they're part of a MAT treatment program that you identified, or are receiving medications, outpatient agonist medications that you've identified because you're such a good practitioner and you're using your your prescription monitoring drug program, or at the time of delivery in a patient who's previously identified as a patient that uses illicit drugs, or again, an acute clinical emergency such as a placental abruption or severe hypertension. These are the approved screening tests in pregnancy or verbal screening tests. So the NIDA quick screen, which is probably one of my favorite, but many EMRs have an embedded tool, and so I encourage you to use that specifically because it documents your screening. And then the 4Ps Plus has been validated, and we'll talk a little bit about that, but basically it's assessing the use in parents, peers, partners, past, and pregnancy. And then substance use risk profile pregnancy, the SERP tool. So this is just a picture of the NIDA screening tool, and there is a link on the previous slide how to get to it, but basically it's very easy and it's really helpful in educating and communicating with the patient. So you start the tool, and then it gives you parameters on alcohol, tobacco, prescription drugs, and illicit substances. And then it goes into a little bit more detailed parameters, like in the past 3 months, have you used with a friend? Have you ever tried and or failed to control using substances? And then it's really nice in that it gets into the details of the substances, acute, long-term versus whether they're using in combination. And then it gives you ideas how you can educate your patient on the medications available, as well as behavioral therapies that will be most ideally used for your patient. And then it also, up in the top, you can see it gives you, it'll help you determine whether it's low, moderate, or high risk use. And then finally, you can use this to help kind of educate the patient to where they are in their spectrum of use disorder. So the other very nice thing is that it can be very quick. If a patient has no substance use disorder, so again, every patient, every visit, it's never, 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 and or, you know, it could be one for alcohol, and then you're done. That's it. It's a 1-2 question and done. So really highly recommend this. The other tool that I mentioned was the 4Ps, and it's very popular in pregnant and parenting women. However, it is a proprietary tool, and it does similar. It gets into a little bit more about the relationships associated with substance use. Again, it's a proprietary tool. They are doing a 5Ps, and they're validating for that, which is a tool that's being used similar aspects, but it won't have a cost to it. But just so you know that it is a cost tool and can be quite costly if you're using it for many patients, and if you were to use it as a universal screen tool. So objective number 2, describe recommended medical and behavioral therapies in pregnant patients with substance use disorder. There's the medical component, and I like to tell my patients that's a little bitty tiny bit of what we can do for you. We can help you with medicines. And then there's the behavioral care that is important and very needed to help you obtain and maintain abstinence. And then finally, the bigger piece is the support and family support and the community support. So we have that dialogue together, the patient and I. These are some of the different substances, and then there are different medical treatments. Methamphetamines I'd like to highlight because it's becoming more and more the predominant player in substance use disorder, and there is no medical treatment for methamphetamines. It's very much behavioral treatment driven, with contingency management being a shining star in that space. This is the ASAM criteria. It's very helpful in helping us identify the level of care that our patients need. Early intervention is, you have a high risk drinking pattern. Let's talk about that. And that's the assessment and then the education, all the way to somebody who has comorbidities, both medically and psychologically, and the level of care that may be needed for them. And then this is, again, ASAM criteria, but specifically for withdrawal management. So let's just talk about a little case. So we have a 21-year-old gravida 2 pair 0101. She presents in her first trimester. Your medical assistant has pre-screened your patient and she admits to using heroin, cannabis, and nicotine. She denies alcohol use. Patient states this is an unintended pregnancy but desires a desired pregnancy. She does not have a history of opioid disorder, and I'm sorry, overdose. I've done that twice. Of overdose or prior treatment for substance use disorder. She reports a 6-month period of increasing use and has attempted to stop smoking without success. And the smoking here would be the heroin and cannabis and nicotine. But she wants to now that she's found out she's pregnant. And she tried on her own. She experienced flushing, chills, myalgias, anxiety, and restlessness. When discussing behavioral therapies, she's receptive and she has no medical problems or psychological problems identified. So for this, we'll go back to that levels of care, the ASAM. And so for her, you'll see here, no significant withdrawal, minimum risk of severe withdrawal. She has no biomedical, no behavioral, other than I did underline here mild severity because she has a substance use disorder, and that of course is a DSM-5 diagnosis. And then readiness to change. She wants to change. She's very motivated. It's often that our pregnant patients are quite motivated. They see new hope in the fact that they're pregnant. They can imagine a new life, and so it's not uncommon to have a quite motivated patient who's in pregnancy and wanting to keep their child. And then you want to assess the relapse potential. And then, of course, the very, very important, and this is probably the most challenging piece of what I have to deal with regularly, is the home environment and or the environment closely to where they're living. So I've had patients who are going back into a non-sober home, and or even if the home's sober, they walk right out the front door and they're in an environment that is quite risky, has lots of triggers, cues, and very tempting to relapse. Here are some of the referral sources. I highly recommend the top resource. It's very nice because it is the AA online meeting directory. Everything is virtual, but you can find meetings specific, women's only, women's specialty groups. So I think that's a real nice resources. And then there's many of our local resources on this page, and I highly recommend a lot of our community treatment centers and placement centers. And so this is the page, and I'm sure these are all going to be shared with you all, so I won't go into all the details here. This is a great review out of the Society for Maternal Fetal Medicine. It was a special report that came out last year. And it talks a lot about the different methods of treatment, screening, but also gives a lot of communication on the research potentials that are available. And there are many. And then this is a telementoring program that I run twice monthly. And we invite all comers to come and just get on Zoom and listen to. Generally, we invite a either regional, national, and often local speaker to present for 10 to 20 minutes. And then we go through some cases to help us all manage our patients and do a little bit better practice in care and learn. And then finally, I just wanted to talk about the fact that we've been given a lovely grant through the Howley Foundation and access to start an intensive outpatient program at Banner University Medical Center, which is the primary affiliate for the University of Arizona. So it'll be a co-located OBGYN and family medical care program with a group prenatal care and then an intensive outpatient program for our patients with substance use disorder. And with that, I am done, possibly early, but I'm sure it gives us more time for questions.
Thank you very much, Dr. Manriquez.
Absolutely.
So we're going to go to our third and final panelist. Remember, we'll be bringing all three panelists back at the conclusion of our third presentation, and we'll take as many questions as we can from the Q&A box. Again, if you have a specific question, then please make sure that you've noted the name of the person. Our third finalist is Lachey Brown. She began her work as the sexual violence response coordinator at the Arizona Coalition to End Sexual and Domestic Violence in July of 2019. She is driven by her passion to serve others and to center the needs of communities that have been pushed to the margins. She began her work as a crisis responder in Flagstaff, Arizona, and has been committed to advocating for survivors and anti-violence work since then. She graduated from Northern Arizona University with a bachelor's in criminology and criminal justice with a specialization in victimology and 2 minors in social work and ethnic studies. Lachey is happiest when reading a new book, dancing, playing mini golf, and being an active member of her adopted community. Please welcome Lachey.
Okay, thank you everyone, and thank you for introducing me. So this is innovative approaches to supporting Arizona's women through a range of circumstances. My name, as was said, is Lachey Brown. I use she and her pronouns, and I'm one of the sexual violence response coordinators at the Arizona Coalition to End Sexual and Domestic Violence. I have no conflicts of interest to disclose, and with that, let's begin. Next slide, please. So here are our learning points. We're going to overview how pregnancy, miscarriage, or recent births may be impacted by experience of sexual or intimate partner violence. Then the common barriers that women face in accessing sexual or domestic violence services. We're going to then review the recommendations for clinical and non-clinical providers to identify women who are at risk. And then lastly, we're going to review some community resources that providers should be able to refer to quickly or to quickly reference when needed. Next slide. So what is the scope of the issue? Why are we talking about it? Why is a sexual violence provider at this conference today? Because the scope of the issue is so wide and so broad. So if we look at the amount of people who gave birth in the United States, about 1 in 3 experience some form of contact sexual violence, and about 1 in 4 experience some kind of contact violence by an intimate partner. So we know that people who are pregnant die by suicide or because of medical complications, but we also have to focus on how these pregnancies are affected by interpersonal violence as well. Next slide. But that doesn't mean that all women are impacted by this issue equally. So Black and Native women experience higher rates of maternal mortality, and Native women, as we've heard from several Native providers today, experience some of the highest rates of sexual violence and intimate partner violence. And particularly if you want to really read and dive more into this issue for Black women, I would suggest you read the Sexual Abuse to Maternal Mortality Pipeline Report that was just put out by Black Women's Blueprint in 2018. It has a plethora of testimonials and data, and overall it was a really well-done document that shows how sexual violence is connected to maternal mortality. Next slide. Well, what are the traumatic impacts of sexual and intimate partner violence, and how does that impact women who are coming to healthcare settings? So we have to think about how physical touch and that invasive touch might be very traumatic for those who are coming in to receive medical care. Again, a stranger or someone they don't want to touch, and that can be very triggering for survivors. There's also that loss of control of their own bodies. So a lot of us who are coming in to receive these services aren't doctors. And so there is an inherent power imbalance of not only what's being done to their body and for their body, but also the information that they have about their bodies. There's also that loss of privacy. So when someone comes in, they have to tell and explain to their medical provider about something that might be very personal and very private to them. And then also they might feel like there is that judgment or shame because of what they've been doing to keep themselves alive. And from there might be these triggers or flashbacks that might be started by that unfamiliar touch or being in an unfamiliar setting or environment, that especially with people that you might not be familiar with on a daily basis. And again, there's that power dynamic. Who has the information, who has the resources, and then who is also in need that we have to think about, especially with those who have traumatic histories. And then there might be that unfamiliarity or distrust of systems, or that distrust of a stranger, right? We are not chatting it up with our doctors on a Thursday night about what's going on in our lives. We're really coming there to seek a service and seek resources and to seek medical care, which can be really formal in a lot of settings, and that isn't an easy way to engage or access information. Next slide. So the traumatic impact is one of the barriers, but here are some other ones that we have to think about when it comes to people accessing services. So if they are experiencing intimate partner violence, they might also be dealing with that abusive partner trying to remove them from these services. They also might have to deal with their previous negative experiences with healthcare. And just because they haven't necessarily had a negative experience with you, they've had to probably go to receive medical attention sometime in their lifetime. And those negative experiences are often more impactful than the positive experiences we have. They also might associate healthcare with pain and judgment, right? With a lot of communities, going to the hospital a lot is shameful, and it also could bring on a lot of fear, especially for those who are pregnant. There might be a lot of fear of what happens in medical settings. What if that person is truthful? If I'm truthful with my healthcare provider, are they going to make a report? Are they going to take my child away? Are they going to judge me for what I'm going through or how I'm living? And what happens if I refuse some of these services? And a lot of these feelings we know can be dissuaded when met with empathy, honesty, and information, but that isn't the response that a lot of people receive. And so that information and those feelings disseminate within communities. And so this distrust continues. There might also be an unawareness of what services are available. So for some of the things that are being talked about today at this conference, I wasn't aware of them. And as a service provider, if I'm not aware of them, I might not be informing people that I work with. So again, there's just, this lack of information between systems. And therefore, if there's this lack of information between systems, there's a lack of information going to the people that we're all serving. There might also be some logistics involved that might make it more complicated than showing up for an hour appointment. What if I have to get on the bus to go to this appointment, but the bus comes only 4 hours before my appointment or 1 hour after my appointment? How am I going to get there? How am I going to provide childcare because my children are now doing school from home, but I don't want to take them to this appointment? It's going to be a lot of work. So now I have to pay someone to come watch my child or find someone to come watch my child. What if I can't borrow the car at this time? So there's a whole lot of logistics that might come into what we just see as 1 hour-long appointment that we have to consider. There might also be some financial issues. We know that healthcare can be very expensive and very complicated. So trying to understand how you might be able to access some of these services for free or find a way to mitigate some of those costs might be very difficult for survivors. There's also those cultural considerations. So recently, especially for Black women, the medical bias in healthcare has become a major issue. And so many pregnant mothers are aware that this belief of Black women regarding pain management, and symptoms can be very well life-threatening. So we have to consider that and all these different barriers a person might face when they're talking about receiving some of these services. Next slide. But there are ways that we can try to address some of these things. One of the intervention methods that's been found to be evidence-based is CUES, and this was put forth by the Intimate Partner Violence Health Partners organization and made in conjunction from an organization that we take a lot of TA and information from called Futures Without Violence. Now, it was called CUES, and CUES stands for Confidentiality, Universal Education, Empowerment, and Support. So what this intervention is really based around is it gives 2 cards as a part of the universal evidence-based education intervention. And then from giving those 2 cards, we go through these couple of steps. So the first is confidentiality, and that's when the provider will disclose the limits of confidentiality with the patient alone, which is a key part of this intervention method before discussing intimate partner violence. Then there's the universal education, and that means that we're making sure that everyone has access to the same information that's accessible, and it helps the patients understand healthy and unhealthy relationships and their impact on the health of themselves and also their child. Then there's the empowerment piece, and again, it's giving the patient those 2 safety cards to promote their health and healing so they can help, or so they can give one to help someone else in their social circle. And then lastly, it's of the support piece, which is offering the patient harm reduction strategies and a warm referral to an advocate when appropriate to promote safety. So again, it's seeing and doing the screening, but then also providing some follow-up and some resources. Next slide. But what else should we be considering when we think or suspect that someone might be being harmed or might be in danger? We need to think about larger ideas of safety. So safety looks and feels different ways for many different people, especially for pregnant women. We can't just look for cuts or bruises. We have to think about their spiritual safety, their relational safety. So are they safe with the people that they're around? Are they free to express their sexuality and their emotions? All of these things are part of a holistic approach to safety, and they're all things that we need to be considering as service providers. Trust is also very essential. We build trust by building relationships. So that starts with actually making those connections with folks. How we need to make sure that how we're learning about their lives. So asking questions like, how we're learning about people's lives, so not just going down a checklist to see and asking all those medical questions, and thinking about how are we informing them about ourselves and our role as a trusted person and as a person who's supposed to help them. So giving out some details about ourselves, like where we're from, how we're going to help them, and making ourselves just a little bit more personable, and again, forming those personal connections. It also means that we have to be intentional about the time we spend and actually make investments in those relationships. It's also considering what a collaboration truly looks like. So our services and the services that are being offered should be patient-led, and a true partnership means that folks and the folks that are involved can make informed decisions, not just vaguely consenting to what's being offered. And we should feel like that we're working together, not that one person is working for or around the other. And we also just want to remember that they may be one of your patients, but for them, this is the only pregnancy that matters. So we should make sure that they feel like we're valuing them, their time, and their healthcare as well. And then we also want to think about what choices can we offer them during our interactions. So we call them touch point choices, and they're things like, would you like the door open? Would you like a support person to come to the appointment? Would you like me to explain this again? Again, so a key part of interpersonal violence is about that power and who has power. And when we give people space to make their own choices and decisions with our support, that can be very helpful. And then the last piece is empowerment. So we ourselves cannot empower anyone, but what we can do is to validate their experiences, provide information, and support them so they can then empower themselves. Next slide. And so after you do the screening, after someone says, yes, I want resources, what do you do then? We highly suggest that you then refer them to some community resources. So you should be able to find your local sexual and domestic violence program on our website, and we have a whole, like I said, there's a whole list that gets updated pretty regularly of all the sexual and domestic violence programs throughout the state. You could also refer folks to community-based programs or to family advocacy centers, and they have resources as well. You could also refer people to virtual services. So there are some resources and information on the Move to End Violence website. And then if you want to start forming your own policies or get some more training about how interpersonal violence connects with some of your research and some of your work, you can reach out to us for training and technical support. That's actually part of my job, is to provide training and technical support for sexual violence throughout the state. Next slide. But I really couldn't emphasize more that we need to make sure that we're collaborating between the anti-violence field and the medical field, because there is so much overlap there. And if we're really going to reach the people who need our help the most, there has to be that collaboration. And you all can make a difference. So though disclosures do happen in a medical setting, it is vital that we, and you all as providers, know that disclosure is not the goal. The goal is to ensure that the patients understand the connections between their relationships and their health, that their healthcare providers are trusted resources, and demonstrate and we demonstrate that we are trusted resources, and what resources and community-based options are identified and available to improve health and safety options. If you get nothing else from this training and this presentation, know that empathy is key. When we're empathetic, even if we're not able to provide someone with the answers to their questions, they'll remember that we at least cared about what they were telling us and what their problem was. And it was found that women who talked to their healthcare providers about experiencing abuse were 4 times likely to have some type of intervention, such as advocacy, counseling, an order of protection, or shelter. So that means that you all are making a difference. And that means that we need to make sure that we're doing this screening, that we're being empathetic, and that we're listening to the patients that we serve so we can have a positive impact on their lives. And I think that is the end. Thank you all for listening.
Thank you very much, Lachey. So we will go to our panel questions, and we're going to start with Michelle. So Michelle, how long after birth is the peak incidence of postpartum depression and anxiety?
It's a great question. So one of the reasons we recommend screening through the first year postpartum is because if you look at the literature, it may indicate the peak is at 4 to 6 weeks postpartum, and then we may see a decline, but then an increase around 6 months. But then we also see an increase, some of the literature indicates, at 9 months postpartum. And so what we have to consider is what is also going on in that woman's life. There's the hormone piece of it and a biochemical piece of it, but there's also that psychosocial piece of it. And I think the literature helps us support that first year postpartum. So we don't want a mom to be discharged from treatment and then not be prepared for that increase that can occur at the 9-month mark. Maybe she's weaning at that point. Maybe baby's not sleeping at that point. So that's some of the information that's out there in the literature. So it's all over the place, which is why we do it within the first year.
Thank you. Maria, I know you had a lot of resources listed on your page. Specifically, are there any resources for recovery for uninsured patients, which is the majority of this person's patient base?
Sure. Well, in Arizona, the Medicaid, which is access coverage, is at probably 200% of poverty. So most pregnant women in Arizona, given that they are documented, will have insurance. At least access insurance. And those that don't have insurance because they're not documented, then I worked for years at Valley Wise, and we have a nice maternity package would include that. And then the pharmacy, there is probably the least expensive pharmacy available. So that would be a recommendation. But again, we really try to make sure that all of our patients that can qualify with access are plugged into the system. And the only patients that I've found that aren't available to that is someone who is not documented, and or somebody who has completed their pregnancy and still need those services.
Right, thank you. Lachey, your first question. Could you please describe some of the systemic legal challenges in Arizona that hinder the reduction of IPV? So firearms, paternity tests, judicial precedents, etc.
So Natalie, that is a loaded question, and there is a lot of different answers. I think one of the biggest legal challenges is that the criminal legal system was not set up to properly serve survivors of intimate partner violence. So now we are trying to go back and fix all the problems in a system that was never designed to work for survivors. So that means we have to think, when we're talking about things like firearms and how there is now a law that says that people have to submit their firearms, but there's no process about how to do that. So again, that's a gap. On the sexual violence side, we know there is, for children who were conceived through rape, there is a problem with getting a conviction. So there's another gap there. So if someone is not convicted, then they still might have access to some types of custody. So that's a problem there on the sexual violence side. So again, there's so many different things that we could talk about with paternity tests, with child support enforcement, but we really don't have time to get all of those issues today. Just know that it's very nuanced, and that because of all the gaps in the systems, it makes it hard for survivors to really start anywhere and to get any of those services because of the way the legal system is set up.
Thank you for that. Michelle, your next question. There are 3 CPT codes that can be used by health providers to screen and bill for mental health screening. Do we know if these codes are being used by health providers? And if so, what is the screening rate with these codes serving as a proxy for understanding the prevalence of mental health issues in this population?
Well, as far as we know, is that the private insurance is not paying for screening. But we know with the Medicaid plans, we bill the HCPCS codes, and for mental health screening, we get paid. The rate is about $22 per unit for screening. I don't know that. What was I'm sorry. The second part of that question.
The second part of that question is the do we have if we understand the screening rate with these codes, is it a proxy for understanding the prevalence of mental health issues in the population?
I don't believe so, because we're not getting paid for it from the private insurance, and we're also missing a large percentage of women. So we're not getting a good idea at all.
All right, thank you. So Maria, your next question, how does maternal peer support improve outcomes for women struggling with drug addiction and or co-occurring disorders? And do we have a resource to offer maternal peer support in Arizona?
So fortunately, most of our services that do provide intensive outpatient and standard program care do have peer support associated. That's one of the factors that we're trying to make sure we implement within our IOP. And absolutely, me telling someone the risks and the benefits is very different than somebody who's listening to it from somebody who's experienced the just the trauma, the negative effects, and walked the same path. So very valued, and certainly it would be remiss to leave that type of person out of any program.
All right, thank you. Lachey, your next question, what resources do you recommend for women experiencing IPV while experiencing homelessness?
Yes, so I would suggest you reach out to one of the local sexual and domestic violence programs, because we have resources. We have access to shelter, to counseling, to healing services, to legal services as well. So I would definitely reach out to one of those programs. Again, you can find a list of the programs that are in your community on our Arizona Coalition to End Sexual and Domestic Violence website. And you have a list of all the programs within your area. So there are definitely many programs statewide. So again, I highly recommend you reach out to some of those programs, because that is one of the best ways to get connected to services. And I also want to add that some of these services are mobile. So that means that an advocate will come meet that person where they are, whether it's on whether it's a McDonald's, whether it's their home. There are mobile advocacy programs throughout the state to come reach people where they are, because we know not everyone can make it to our programs and to our physical doors. So yeah, reach out to some of those programs, or you can reach out to our helpline at the coalition, and they can help you narrow down where some of those resources might be.
All right, thank you. Michelle, what other screening tools are available other than the 10-question EPDS?
One of my favorite is the Postpartum Depression Screening Scale by Cheryl Beck, and it's used specifically for clinicians, and it looks at 7 different categories like identity, sleep, anxiety, suicidal ideation. It's validated for perinatal women. The PHQ-9 is also, but I'm in agreement that moms can falsify how they're feeling. They can just go nope, 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 nope all the way through, which is why the screening tool is a great opportunity to have a conversation. See the woman in front of you, understand what her experience is. So even if she scores a 3 on her EPDS and you're understanding who's sitting in front of you, you might have a better idea of what she's going through. But the Cheryl Beck's screening tool is one of the better ones because it's more involved. It's 35 questions.
Thank you. So Maria, will the IOP at Banner University be tailored specifically for the expectant and parenting families?
Specifically. Yes, that's exactly what we are doing. It is totally for pregnant mom and parenting mom and bringing the family together, bringing their children. We're hiring a child care specialist who will be there to kind of keep, work with the children developmentally while mom's in her IOP, but also let us have an evaluation of how they're doing with their parenting and just modeling from other mothers and bringing families together and really focusing on the family support.
Thank you. Lachey, you're next. When every provider screen every time, it takes 7 times of asking about these issues, and some will reach saturation point and seek care elsewhere. Is that your experience, or can you say more about the experience around the 7 times asking about these issues?
Yes. So I'm not sure about the data about how many times before a person discloses that they're asked, but I do know that when the screening happens, it's usually that survivor can tell that it's a checklist and there isn't that conversational piece where someone feels like you care about them as opposed to just asking the question. So again, we really want to make sure that our responses and when we're asking these questions, we're showing that we're active listening, and active listening looks like making eye contact, looks like waiting for a response, and it also looks like taking into the ways that people communicate, such as their tone, such as their body language, in consideration when we're asking these questions, and then doing some follow-up questions. I know we're all on a schedule, but again, showing that we care can be the difference between just getting your questions answered and actually making that connection so there could be an intervention.
All right, thank you. And this will be our last question for the panel. It's to you, Maria. What are your thoughts about the renewed trend to criminalize women who use drugs during their pregnancy?
I think it's a terrible precedent in every way, shape, and form. There is some positive aspect to court, and I'm blanking on the exact terminology, but court guided mentorship, for lack of a better word, but it's a judge working with a patient individually or a client individually and helping them get on a track. But that's very different than the criminalization. So court appointed therapy.
Right, thank you.
Mm-hmm.
I would like to again extend a very gracious thank you to Michelle and to Dr. Manriquez and to Lachey. We're so happy that you were able to share your wisdom with us during our panel.
Thank you. Thank you for having us.
So today we learned a little more about challenges that too many women and families in Arizona face before, during, and after pregnancy. Unfortunately, we know this is just scratching the surface. There's so much more to discuss, and more importantly, ways that we can collaborate to improve maternal health outcomes in Arizona. We hope that you will join us again tomorrow for the Maternal Health Task Force meeting, where we will get a little closer towards identifying collaborative strategies to achieve our common goal of reducing maternal mortality and severe maternal morbidity in our state. Tomorrow, you will be receiving a link to the evaluation, and this is where you will place your 3 keywords from today. Your third and final keyword is the color blue, B-L-U-E, blue. If you have any questions or concerns about this session or tomorrow's session or either of the live implicit bias trainings later this week, please do not hesitate to contact us. As you can see on the screen, again, the contact information is there, maternalhealth@azdhs.gov. We're looking forward to seeing many of you tomorrow. Until then, stay well and stay healthy, and we will see you tomorrow.